Amit sir, good evening. Your video, you're on time, sir, as usual.
Thank you.
We're just waiting for other two people, so then we'll start.
Okay.
Hi, good afternoon, everyone. I think Dr. Devendra sir is also there. I think Dr. Zamir sir is only left, I think.
Yes, Dr. Amit and Dr. Devendra has joined. Dr. Zamir is yet to join.
So I'll just give him a call. Maybe we should start on time. Is that okay for everyone?
Yeah, just give him a call and then we'll start so that marking can be done for the first paper.
Yeah, I'll give him a call now.
Yeah.
Start sharp at 4 o'clock. Huh?
Okay, sir. Dr. Sonali is there, the first presenter. Are you online, Dr. Sonali?
Dr. Zamir is just logged in.
Yes, sir, I am here.
Yeah.
No, sorry, I meant one of the judges, Dr. Zamir. I think he's just logging in.
Okay.
I think it's showing him now. Dr. Zamir, are you here now?
Yeah, I can hear you. Just hold on a minute. I'll just get myself.
No, it's fine. It's fine. We can take a couple of minutes. That's fine. As long as we're all here, we can start shortly.
Great.
Another minute is there, Dr. Sonali. You can start sharing your screen. Your first slide can be visible so that we can start exactly at 4.
Okay, sir.
The first session is session number 8 on hepatobiliary topics. And
sir, is it visible, sir?
No, not it. The judges for the session will be Dr. Amit Sinha, Dr. Devendra Yadav, and Dr. Zamir.
Sir, is it visible now?
Yeah, now you have to make it screen like a slideshow.
Yes, sir.
Dr. Jagdish, will you please start? I have got to sort out something for Dr. Rawat. I will sort it out with Dr.
Yeah. Yeah, now slideshow is ready.
Okay. Yes.
I think all 3 judges are online. We can start. Dr. Sonali, the topic is liver abscess in infants, our experience. Time starts now.
Yes, sir. Good evening, my respected teachers and everyone. I am Sonali Kelkar, Senior Resident, Pediatric Surgery, Government Medical College and Super Speciality Hospital, Nagpur. I am presenting our experience of infantile liver abscesses. Liver abscesses are rare in neonates and infants. In literature survey, there are isolated few studies found. Majority of liver abscesses result from ascending infection, hematogenous spread, the biliary tract infection, and direct contagious spread. It often presents with ongoing sepsis and results in diagnostic difficulties. The aim of our study is to report our experience of infantile liver abscesses on the basis of risk factors, clinical presentation, and management. We had done a retrospective chart review of 5 infants with duration of 2 years. Parameters studied are age, sex, risk factors, investigations, management, and follow-up. The results of our study as mean age of presentation was around 4 months with female predominance and no risk factors were present in all infants. The common clinical presentation at the time of admission was refusal to feed, fever, and abdominal distension. In clinical assessment, temperature was more than 100 degrees Fahrenheit in all infants, tenderness in right upper abdomen in 2, and abdominal distension with ileus in 3 infants was present. In investigations, blood investigations, leukocytosis was present, CRP was raised, liver function test coagulation profile was within normal limit, blood culture, COVID RT-PCR, HIV status were negative. In radio imaging, ultrasound abdomen was done and right lobe involved in 3 cases, left lobe in 1, and multiple abscess cavities in 1 case. Mean volume of abscess cavity was 100 cc. First culture was sent and Staphylococcus was grown in 1 sample, Klebsiella in 1, and no growth reported in 3 infant sample. In management, IV broad spectrum antibiotics and metronidazole was started in all patients, and USG guided therapeutic drainage via needle aspiration was done in 4 patients. Single needle aspiration was done in 1 and 2 aspirations were done in 3 patients. Catheter drainage was done in 1 patient. After discharge, follow-up was taken in outpatient clinic. In first visit, at the first week of 3 infants were having residual abscess cavity on ultrasound, but infants were asymptomatic. In second
your
week,
time is up. Finish it.
In conclusion, neonatal hepatic abscesses are rare, but should enter the differential diagnosis of neonate with ongoing sepsis. Early diagnosis, antibiotic coverage, and ultrasound guided drainage gave better outcome. Our take-home message is, yes, sir.
Over to the judges.
Hello.
Yes, sir.
Yeah, hi. Your presentation was very nice. I just wanted to know what was your indication of management in these patients? In which patients did you decide for needle aspiration, and which patient, and what is the criteria for decision for pigtail drainage?
Sir, there was on admission, we have started an IV antibiotics to all patients, and there was a large abscess cavity and liquefaction of abscess was the indication for the needle aspiration. And 1 patient, we had done catheter drainage as there was solidified components and liquefied components was present. So that.
Okay, solidified components should not be an indication for catheter drainage, no?
Sir, few solidified and some of liquefying components was present, cavity present, and abscess cavity was large, sir.
Okay.
Yes.
So, Dr. Sonali, what kind of
Yes,
study this was basically?
Sir, it was a retrospective study.
A retrospective study, or it was just a descriptive study of 5 cases?
Sir, we have done only retrospective chart review, sir. So it could be said that it is a disruptive study. Observational study only, not a disruptive also.
It is descriptive study. A descriptive study is a type of observational study. Okay.
Yeah.
Thank you.
Okay. Thank you, sir.
Dr. Sonali?
Yes, sir.
In how many cases you have hepatomegaly? And why did you start the metronidazole? Did you amebic liver abscess was confirmed?
No,
just
sir.
Empirically you started?
No, sir. We started empirically with to cover the anaerobic infection also.
So why the serological test for amebic liver abscess was not done? And what was your protocol for the oral antibiotics after the discharge? For how many days you will give the?
Sir, as there was on clinical presentation, there was a hepatomegaly, tender hepatomegaly in few patients, sir, and fever was the presentation and refusal to feeds. So we kept diagnosis of pyogenic liver abscesses more on, or ongoing sepsis more on. So we didn't go with serology for amoebiasis.
Okay.
Thank you,
And
Dr. Sonali.
leukocytosis was present in patients, sir, with neutrophilic count raised.
Okay, thank you, Dr. Sonali. You can stop sharing your screen. Next presenter is Dr. Manasa. You can start your screen sharing.
Yes, sir.
And we request again for all the presenters to keep your video on, which is actually made compulsory because of so many feedback from yesterday's sessions. Keep your video on while presenting.
Yes.
Dr. Manasa Reddy can share the screen as soon as she stops sharing. Dr. Sonali, you can stop sharing the screen.
Yes, sir. Is it invisible, sir? No?
Yeah, visible.
Yeah.
Visible?
Yeah.
Yeah, you're
It's
visible.
visible. You can start, Dr. Manasa.
Your screen is visible.
Good afternoon, all. Greetings from PGI Chandigarh. I'm going to present a rare case of biliary atresia associated with splenic malformation with situs inversus. Biliary atresia is a progressive inflammatory sclerosing cholangiopathy of biliary ducts and is rarely embryonal or congenital in nature, known as biliary atresia splenic malformation, and has a variable incidence. 6% incidence was noted in an Indian scenario by Safwan et al., and Western literature shows an incidence of around 10%. It is associated with various malformations like asplenia or polysplenia, rotation anomalies like heterotaxy and malrotation, cardiac or vascular anomalies such as pre-duodenal portal vein, interrupted or absent IVC. Our patient was a 58-day female child born preterm at 34 weeks of gestation, presented to us with history of progressively increasing jaundice since day 5 of life and clay-colored stools and high-colored urine since birth. On examination, she was icteric and heart sounds were heard predominantly on the right side, and liver was palpable 5 cm below the left subcostal margin, firm in consistency, and had a smooth surface and irregular margin. Investigations revealed a high total bilirubin of 12.2 with a direct component of 5.4, and ultrasound showed small contracted gallbladder measuring 16 mm in length, and 2D echo revealed dextrocardia, and HIDA scan showed preserved hepatocyte function with absent bilioenteric drainage. Then we proceeded with surgery, and via left subcostal incision, intraoperative cholangiogram was done, which showed no passage of dye into the duodenum, and liver was enlarged, firm in consistency, and dark green in color, and polysplenia and stomach were noted on the right side, and DJ flexure was in the midline. Here we can see atrophic gallbladder, which was dissected off its base, and portal plate was dissected between the portal vein bifurcation. And Roux loop was taken 15 cm from the DJ flexure and placed between the duodenum and the transverse colon, and subsequently portoenterostomy was done. On post-op day 5, the baby passed green color stools and was orally allowed and was discharged on post-operative day 8. At 1 month follow-up, she was non-icteric, passing occasional ecolic stools, subsequent to which prednisolone was started. And at 3 months follow-up, she was passing normal color stools and had a total serum bilirubin of 2.2 and normal liver enzymes. Histopathology revealed extrahepatic biliary atresia with portal fibrosis, ductal plate malformation, and bile ductules were showing a maximum diameter of 300 to 500 microns. Biliary atresia splenic malformation results from an early embryonic insult, approximately at 20 days of gestational age, and carries a very poor prognosis. To conclude, heterotaxia and associated anomalies pose intraoperative difficulties, and one should be prepared for the modifications and additional intervention which may be required. Thank you.
Thank you, Dr. Manasa. Dr. Manasa, you can stop sharing the screen so that the next presenter can be ready. Now over to the judges for discussion.
Can I make a comment? I'm Dr. Rajiv Redkar, pediatric surgeon.
Yes, sir. Sure, sir.
Yes, sir.
In cases of biliary atresia splenic malformation, it may, with the situs inversus, as you had shown, it may be beneficial to have access to the biliary enteric anastomosis that you are making. So I saw that you had an end anastomosis done, end of the loop to the portal plate. If you do a side anastomosis and hitch it to the parietal wall, then these are the children who complicate subsequently. So you need access to the loop after the surgery. So that can be done by vascular team. So they can gain an access with a needle. So that is all. That is a comment that I would like to make. Thank you so much for a nice presentation.
Yeah, hi, Dr. Mansa. Dr. Zamir here.
Yes, sir.
Yeah, very nice presentation and amazing, lovely pics, intraoperative pics you have. One question what I have is, if you have a patient with biliary atresia with situs inversus, what is your preoperative imaging criteria? What would be your idea about preoperative imaging criteria for these patients before surgery? Like for biliary atresia, we just do an ultrasound and operate. Yes. If you suspect situs inversus, do you want to do anything more, or you're happy with this?
We can do a CT abdomen, CT abdomen.
How will it help? No, did you haven't done CT in this case, is it?
No, we haven't. I mean, to gain more anatomical knowledge, and if we, intraoperatively, we can avoid maybe surprises. And
intraoperatively, what things do you want to look out for in these cases with biliary atresia, splenic malformation cases in biliary during Kasai? What are the things intraoperatively in BASM that you would look out for, which will change the prognosis of a patient as versus a patient with isolated biliary atresia? Which things will change the prognosis is what I'm asking.
Prognosis, I am not sure, sir.
Yeah, that's fine. That's good. Anyway, your presentation was very nice. Your pics were very good. Yeah. Thank you.
So, is it necessary to do this cholangiography in all cases? You are doing in all cases or in selective cases, Dr. Manasa?
Sir, we are doing in most of the cases, unless we find completely atrophic gallbladder with no lumen, we proceed directly to Kasai. Otherwise, we usually proceed with the intraoperative cholangiogram.
Okay.
Dr. Devendra, sir, you want to ask any questions, sir? Or you can proceed to the next.
No, proceed with the next. I think
thank you, sir.
Time has been passed. We should proceed.
Dr. Garvita can start sharing the screen. A presentation on EHPVO.
Yes, sir. Good evening, everyone. Is my presentation visible?
Yes, it is visible. Continue.
Thank you, sir. Good evening, everyone. I'm Dr. Garvita from Sir Gangaram Hospital. I'm going to present a case of EHPVO with vascular malformation with chronic volvulus of small bowel. It was managed with splenectomy, linorenal shunt with resection and end-to-end jejunolial anastomosis. A 5-year-old boy, known case of EHPVO with hypersplenism, presented to us with recent onset colicky abdominal pain and bilious vomiting. On clinical examination, he was in small bowel obstruction with right inguinal hernia, and the imaging suggested jejunal obstruction with proximally dilated bowel loops. No history of GI bleed was there. Now, CT angio abdomen was done, in which the portal vein was blocked and the splenic vein was visible with a diameter of 6.21 mm. Spleen was enlarged and there were multiple collaterals and portovenous cavernoma was there. Now, on exploratory laparotomy, there was a bowel mass in the right inguinal region comprising of jejunum and ileal loops, which was adhered to the parietis. The spleen was engorged and enlarged. Now, splenectomy and LR shunt were done first, and we waited for a few minutes for bowel congestion to decrease. This was the left renal vein, and this was the splenic vein which was harvested after splenectomy. And after clamping, we did the splenorenal shunt. Then this is a diagrammatic representation of the operative procedure we performed, and this is the anatomical representation of this proximal linorenal shunt which we did. Now, after waiting for a few minutes, the congestion decreased and we detwisted the bowel, which was completely entangled, and there was a large mesenteric defect, which was probably the cause of the volvulus. Now, after that, we did the resection of the obstructed bowel, and end-to-end jejunal-ileal anastomosis was done along with the right inguinal hernia repair and appendicectomy. This was the histopathological mass, which we sent for histopathology examination. And on HPE of the gut mass that we sent, there was a vascular malformation, which was leading to volvulus of chronic nature. The engorgement of vessels secondary to portal hypertension probably led to acute presentation with bowel obstruction. And the vascular malformation presenting in this way with portal hypertension has not been reported before. The sequence of surgery is important, and the portal pressure needs to come down before we do the bowel surgery. Thank you.
Dr. Gavita, you're very well within time. Over to the judges.
Hi, Dr. Gavita, Dr. Zamir here. Excellent case and very nicely managed to do a shunt surgery along with resection anastomosis and all is very nice. Kudos to your team. A few things as a case with just a shunt surgery, if you do, and you do a shunt with a child with resection anastomosis. Yes. Post-operatively, what is it that you're worried about? What would you be worried about in these cases?
So as there was more of the bowel handling and the bowel was not extremely good, and this was congested bowel, so there was high chance of remaining in ileus, and adhesive obstruction chances were higher. So we had to go slow with the feeds in this patient compared to the other shunt surgeries we do.
Okay. And just coming back to portal hypertension, if you look at a patient with if isolated, you forget your case with small bowel obstruction. If you have a patient with portal hypertension and you have to look about two surgeries, one is central shunt, that is splenectomy, and a splenorenal shunt, or a side-to-side splenorenal shunt, which cases would you prefer to do what?
So first of all, I prefer central linorenal shunt, in which there is hypersplenism features or there is enlarged spleen. We need to resect the spleen as well. And also it is more feasible and more easier than the side-to-side anastomosis as I have seen in our practice, sir.
Okay, thank you. Thank you.
Thank you, sir.
Dr. Garvita, Dr. Devender here. Is there any sign of splenic inflammation in your case, splenitis?
Splenic, sir?
Any sign of splenic inflammation during surgery? How will you assess that there is splenic inflammation is present or not? At which finding will suggest that there is a splenic inflammation present.
It will be more difficult to dissect, and the planes will be more difficult to find to dissect.
Okay. There will be more adhesions.
Yes, sir.
Thank you.
Amit sir, you want to ask something?
No, proceed.
Okay.
Hello, Dr. Garvita.
Good evening, sir.
I am Dr. Ashish here. I just wanted to know the present status of the patient, like what is happening to the patient after the surgery. Is the patient on your follow-up?
Yes, sir. The patient is on follow-up. We did a Doppler scan on ultrasound, and the shunt was doing fine. We did only 3 months back actually the surgery, so it has been only 2 follow-ups since then, sir.
Okay, so do you recommend any anticoagulant or anything after the surgery?
Yes, sir.
And
yes,
for
sir. We do recommend. We have a pediatric hemato-oncology team, sir. So we do surgeries in collaboration with the team. So most of the time we prefer anticoagulants, sir.
Okay, thank you. Thank you very much.
Thank you, sir.
Thank you, Dr. Garvita. You can stop sharing the screen. Next presenter, Dr. Himanshu, can start sharing his presentation of spontaneous perforation of common bile duct in children. I request you to switch on your video while presenting. And as soon as the presentation is over, you can stop sharing the screen while discussion is going on. Dr. Himanshu, you can
hello.
Switch on your video and then start. Your presentation is visible. You switch on your video and then you can start.
Yes, sir.
Now you have to share your screen again because while you're switching on the video, the screen has gone. Dr. Himanshu,
yes,
you can
sir.
Share your screen and then start. It's time.
Is my screen visible, sir?
Not yet.
Your PowerPoint presentation is not visible. You are visible. Himanshu, we are waiting for you. Can we
Dr. Himanshu, if you have any issue, we can move on to the next presentation and we can come back to you. You have any issues?
Sir, can I present next, sir?
Yeah.
Okay.
Next presenter is ready. Dr. Rahul, are you ready with the presentation?
Yes, sir, I'm ready, sir.
Yeah, Dr. Rahul can share your screen and you can start.
Yes, sir. Is my screen is visible, sir?
Yeah, visible. But you have to go to the slideshow mode.
Yes, sir, going.
Yeah.
Can I start, sir?
Yeah. Your time starts now.
Yeah. Good evening, everyone. I'm Dr. Rahul from Leelavati Hospital. I'm presenting a case of double gallbladder with an unusual biliary anatomy. So this case is about a 4-year, 3 months old male child who presents with upper abdominal colicky pain along with fever and non-bilious vomiting. Patient has history of similar episode 1 year back where USG was done, which was suggestive of duplication of gallbladder. On examination, patient was ecteric, sick looking. Vitals were stable, while on abdominal examination, it was tender and guarding present. We did the blood investigation in which serum amylase and lipase were high, and the USG was suggestive of acute cholecystitis of both gallbladders. So till this point of times, we have a diagnosis of acute pancreatitis along with the acute cholecystitis of both gallbladders. We managed the child conservatively, and once child has settled, then we went ahead with the MRCP. On MRCP, it showed duplication of gallbladder with two separate cystic ducts with dilated CBD having intraductal calculi and a long dilated common channel presented with 12 mm of intraluminal calculus along with a type 2 polyducal cyst. Prominence of IHBR was there along with peripancreatic fluid and peripancreatic, pericaval, and perihilar enlarged lymph nodes were noted. So these are the MRCP picture you can see. So these are the filling defects that were the calculi. And there was a query stricture which was there between the right and left hepatic duct on the MRCP. After this, we went ahead with the exploratory laparotomy. On exploratory laparotomy, we did intraoperative cholangiogram. On intraoperative cholangiogram, we saw two gallbladders having two cystic ducts draining into a common bile duct, and the query that we were having on MRCP for the stricture was not seen in the intraoperative cholangiogram. So after that, we went ahead with the dissection, and we went till the head of the pancreas and removed the double gallbladder along with the CBD and make a rule loop anastomosis of jejunum with the CST. So hepaticojejunostomy was done. This is the picture of that hepaticojejunostomy that was done. After, in this picture, we also saw one broad-based Meckel's diverticulum and one splenculus that was left untouched. And on follow-up, 8 months follow-up, there is no episodes of abdominal pain. LFTs are normal, and follow-up USG showed no abnormality of the IHBR. For double gallbladder, we have a classification known as Harlath's classification. He divided double gallbladder into type A and type B. On type A, we have septate, V type, and Y type gallbladder. While on type 2, it is H type, ductular, trabecular, and triple gallbladders are there. The exact etiology of choledochal cyst is still unclear. Some researchers believe that pancreatic juice reflux into the biliary tree plays an important role in choledochal cyst, while an anomalous pancreatico-biliary ductal junction or sphincter oddi dysfunction can cause pancreatic juice reflux. To conclude, I would like to say that
Rahul, your time is up.
So it is a case of gallbladder duplication with common pancreatic biliary channel with type 3 choledochal cyst. MRCP is useful tool to delineate the anatomy in such complex biliary anomalies, and cholecystectomy with disconnection of biliary system from pancreatic system helps in resolution of such anomalies. Thank you.
Dr. Rahul, you can stop sharing the screen. Over to the judges for discussion.
Okay, sir.
Yeah, hi, Dr. Rahul. Dr. Zamir here.
Hello, sir.
Very interesting case and nice pics and very nicely managed.
Thank you,
A couple of questions. What I have is you had your child presented with pancreatitis.
Yes, sir.
From the onset of pancreatitis and your what is the time interval between the onset of pancreatitis and your surgery?
Sir, it was 8 to 10 days. We managed the child in hospital only. We have repeated the LFTs. We have repeated the serum amylase and lipase levels. Once the lipase and amylase levels came down, then we have taken for the surgery, sir.
Okay. Do you think it would be a good idea to wait for a few weeks before you go in for surgery in these cases? If so, why?
Sir, we can wait, but in this child, as child was having acute cholecystitis also, and that choledochal cyst was there, so child might be having acute pancreatitis attack repeatedly. So it is better we went as soon as possible after the settlement of acute pancreatitis attack, sir.
Okay. One last question. That you did an intraop cholangiogram. There was a suspicion of a stricture at the junction of the right and left hepatic ducts. If
Yes,
you
sir.
have found a stricture, what would be your plan of action?
Sir, wide resection we have to do in that case, sir.
Oh, thank you. Thank you.
Thank you, sir.
You said in your presentation that this choledochal cyst was type 2, but in conclusion portion you said it is type 3. Why?
Sir, it was given on the MRCP as type 2, but when we went ahead in the intraoperatively, it is seen as a type 3. It was not type 2, sir.
So type 3, it means it was choledococele.
Yes, sir, it is like that.
So how you approached that choledococele?
Sir, we in the CBD, we went ahead till the head of the pancreas, and at that point we disconnected the connection between the pancreas and bile duct, and we dissected it out, sir. And the remaining portion we have make a anastomosis.
It's okay.
Dr. Devendra sir, you want to ask something?
Very well presentation. How do you manage the intraduodenal part of the choledochal seal? And I think in your dye study, choledochal seal is not visible in peroperative cholangiogram.
Sir, for that intraduodenal choledochal seal, we haven't went there. We did a choledocoscopy. On choledocoscopy, we went intraduodenal. There was no stone, nothing was there, so we left that part untouched.
Okay, well, you initially did not mention that you also went for the choledocoscopy. That's why I asked.
So due to time constraint, I missed that part.
Thank you, Dr. Rahul.
Dr. Rahul, could you have done only a cholecystectomy and a sphincterotomy? Do you think that is a possible treatment option for a simple very small choledococele, a sphincterotomy and by ERCP, and cholecystectomy for the cholecystitis?
Sir, as the child was 4 years old only, after the MRCP, we tried for that sphincterotomy by the ERCP, but we are unable to decannulate and the ERCP was failed, sir. So we went ahead with the exploratory laparotomy.
Okay, fair enough.
Thank you, Dr. Rahul. Dr. Himanshu, are you ready with your slides? Can you share the screen? A gentle reminder to the judges that there is change in order. Dr. Himanshu did not present. Dr. Rahul has to be marked now. Dr. Himanshu, you can start presenting. Your screen is visible.
Yes, sir. Good evening, all. I'm myself, Dr. Himanshu Meghwani, JR1 from MCS 6 years program in the Department of Pediatric Surgery from investigates, presenting you a topic, spontaneous perforation of common bile duct in children, a rare clinical condition. This is a case series of three cases. Case 1, 3 years old female child presented with complaint of non-bilious vomiting, multiple episodes after eating, in emergency for 3 days and loose stool for 4 to 5 days. Per abdomen examination, patient had abdominal distension, tenderness with signs of peritonitis. USG abdomen was done, which showed CBD dilated fusiform, maximum diameter of 15 mm with moderate ascites and no dilated bowel loop. We went ahead with the exploratory laparotomy, and the intra findings we found it was 7.7 7 into 7 mm perforation in at the junction of CHD and cystic duct, with the fusiform dilatation of CBD of maximum diameter 2.5 mm and a 5 mm stone in the CBD with bilious fluid in the peritoneal cavity. Diagnosis of choledochal cyst was with CBD perforation with choledochal lithiasis was made, and we went ahead with the cyst excision with hepaticojejunostomy and cholecystectomy. And on the histopath sample which we sent, which showed inflamed gallbladder and CBD. This is a picture intra findings in which we can see that this is the gallbladder, this is the CBD, this is the cystic artery, cystic duct, this is the CHD, and here is the perforation. In the second case also, there was a 4 years old male child presented with complaint of insidious onset of pain abdomen for 2 days with abdominal distension. On examination, and it was shown that patient had distended abdomen with overlying dilated veins. On palpation, it was tense, generalized guarding was present. In emergency, bilateral glove drain was placed and the bilious contents was drained. We went ahead with the surgery of exploratory lab, and the intra findings we found that it was 1.5 liters of bilious fluid in the peritoneal cavity, a small 5.5 mm perforation in the CBD at the lateral surface, about 1 centimeter below the attachment of cystic duct with the dilated CBD of around maximum diameter of 1.2 centimeter. So the diagnosis of choledochal cyst with perforated CBD with biliary peritonitis was made, and when we went ahead with the sixth excision, cholecystectomy and hepaticojejunostomy. Post-operatively, patient did well and was only allowed on post-op day 6 and was discharged in satisfactory condition in post-op day 8. Another patient was a 6-month-old male child presented with complaint of fever and cough for 10 days duration, developed complaints of vomiting, non-bilious, non-passage of stool from 2 days, and again on abdominal examination, abdomen was distended, guarding rigidity was present. USG abdomen showed moderate particulate ascites, visualized bowel loop on right and left side were prominent with sluggish 2 and 4 peristalsis with moderate particulate ascites. So possibility of subacute intestinal obstruction was with bowel perforation was considered based on the USG finding. We went ahead with the surgery, and in the intra-op finding, we found a choledochal cyst of max diameter 2 centimeter with perforation of 5 millimeter in the middle portion of the lateral surface of the cyst. So the diagnosis of perforated choledochal cyst with biliary peritonitis was made. So discussion will be biliary peritonitis secondary to rupture of CBD with choledochal cyst is a rare presentation. Described in less than 2% of the cases. So spontaneous perforation of bile duct should ideally manage with immediate surgery. In case of CBD perforation with choledochal cyst, excision of the choledochal cyst along with cholecystectomy and biliary enteric bypass should be done. Due to less incidence, the index of suspicion for this diagnosis is low, but the bilious peritoneal tap will be, with features of generalized peritonitis may be considered as clue for suspicion. Surgery remains the mainstay of the treatment. Primary suture repair of the CBD is considered unnecessary and even hazardous due to local inflammation. That's all, sir. Thank you, sir.
Dr. Himanshu, you can stop sharing the screen. Thank you. Over to the judges.
Yeah, hi, Dr. Himanshu, Dr. Zamir here. Very nice case scenarios and very well managed. My only question to you is, you have two scenarios, one patient with a spontaneous perforation of the common bile duct, yes, and other scenario is a perforation in the choledochal cyst.
Yes, sir.
So what would be the difference in the line management of each of them from your, what do you feel? Or would it be the same?
Sir, if only the CBD would have been perforated, we can go, we went ahead with the T-tube placement. But as in all the three cases, we with the perforation of the CBD, we had a choledochal cyst. So that's why, and the child was nutritionally good and hemodynamically stable. So that, so we directly went ahead with the hepaticojejunostomy and excision of the cyst and the CBD, sir.
Okay, thank you.
So when you are having perforation in CBD, why not you thought about that maybe a case of choledochal cyst with perforation?
Yes, sir, it was kept in mind, but as the CBD was perforated, so we directly went ahead with the surgery.
No, how you differentiated whether it was a perforated common bile duct or perforated choledochal cyst?
The diagnosis of perforation was made in the intra only, sir, during the at the time of surgery only. In the ultrasound which we done in the first case did not mention about the perforation, but that we found it in a during the intra only, sir.
Thank you.
Himanshu, nice presentation. Why did you not choose the intraoperative cholangiogram in any one of your case? How will it help? Especially in cases of spontaneous perforation of bile duct.
It would have showed any obstruction at distally, sir. We could have gone with that, but we directly went ahead with the excision, sir.
Okay.
Thank you, Dr. Himanshu. I request all the presenters to stick on to the time. Otherwise, if they're prolonging with the time, I think the questioning has to be cancelled because of the shortage of the time. Now, the next presenter, Dr. Gautam, has excused himself for not presenting. So judges have to mark as per the instructions given. They have to mark 1 for all the criteria and then write absent in the comment section in the scoring sheet. I request Arpit Kumar to share the screen. Dr. Arpit Kumar, are you online?
Hello, sir.
Yeah, your slide is visible. You can start.
Hi, sir. I'm Dr. Arpit from the surgery resident first year DNB from Bangalore Baptist Hospital. I'll be presenting about indication and feasibility of emergency laparoscopic surgery in the acutely presenting choledochal cyst. So with the background of the knowledge about the choledochal cyst, so it's a congenital cystic dilatation in the intrahepatic as extrahepatic biliary tree. So it is 3 to 8 times more common in the females when compared to males. It is usually diagnosed in the infancy or the childhood. Even though the exact etiology of the choledochal cyst is not known, the most common pathology we consider as abnormal pancreatico-duodenal duct junction, which causes the reflux of the pancreatic juice, which causes the weakness of the bile duct. So presentation will be usually considered as a triad, that is jaundice, abdominal pain, and the right upper quadrant mass. But usually less than 10% of the patient will present with this triad. The most common presentation in the infancy will be mass. In the childhood, it will be pain. But in the elderly age, it will be jaundice. Investigations include ultrasound, CT, MRCP, or ERCP, but usually most commonly done will be the ultrasound and the MRCP. So we have classification of choledochal cysts. 5 classifications that Todani has classified into 5 types. Most common complications with the choledochal cysts include cystolithiasis, cholangitis, acute pancreatitis, hepatolithiasis, and cholangiocarcinoma. So with this background about the choledochal cyst, so I'll be presenting you a case of choledochal cyst. So we had a child with 8 months old girl presented with abdominal pain and bilious vomiting for the 4 days. And clinically, she is found to have jaundice and fullness in the epigastrium. And on blood investigation, she is found to have direct conjugated hyperbilirubinemia with elevated lipase and amylase. And the ultrasound showed choledochal cyst with central biliary dilatation, but the MRCP confirmed it is type 4A choledochal cyst. So initially, she was managed with antibiotics, analgesics, and IV fluid resuscitation for the initial 4 days in the hospital stay, but her pain was unrelenting, and she was planned for laparoscopic surgery under general anesthesia. So this was the MRCP, which is showing type 4A choledochal cyst. So during laparoscopy, we had one 10 mm port and 3 mm ports. And this is the intraop picture showing the choledochal cyst with the distended gallbladder. And this is the intraoperative images showing the dissection of the cyst and dissection of the transection at the CHD. And Roenway jejunoctomy, we did it extracorporeally. We brought the loop of the jejunum outside through the umbilical port, and we have anastomosis outside, side to side anastomosis were done. But the hepatico-jejunostomy was done laparoscopically intra-abdominally. The child was stable, and she was shifted to PICU for 2 days and extubated on day 1, and she was stable. The drain was kept for 4 days, and the drain was 100 ml total, and it was serous. The baby was slowly initiated feeds on day 3, and she was tolerating full oral feeds on day 4. Drain was removed on day 5 and discharged at day 7. This is the first follow-up picture of the patient after 50.
Time is up.
And she was followed up with repeat ultrasound as well as the LFT, which was normal. Thank you.
You can stop sharing the screen. Over to the judges.
Yeah, hi, Dr. Zamir here. Very nicely managed case of acute infection, and you have done a surgery laparoscopically. That's very nicely done. My 2 questions for you. One question is, intraoperatively, when you put a scope and you see there is a lot of inflammation,
yes, sir.
Less than doing a full reconstructive surgery, what other options do you have?
Sir,
And yeah, go on, please.
Sir, one of the option was T-tube drainage, sir.
T-tube for the choledochal cyst?
Yes, sir.
Okay.
Because it was involved in the complete CBD. So we can try, we would have tried the CBD, T-tube drainage, sir. One of the option was, and we can plan for an elective surgery after 3 to 4 weeks.
Okay. Second thing is pre-operatively, if you had severe inflammation and you have intrahepatic biliary duct dilatation, something, yes, and the child is too sick to go for surgery, even for a T-tube drainage. Any other option you could have, anything else you could have done?
Sir, we would have tried transhepatic drainage, sir.
Yeah, very nice. A percutaneous drainage of the intrahepatic.
Percutaneous drainage.
Good. Very nice. Thank you.
Thank you, sir.
Any questions, Dr. Amit and Dr. Devendra?
I am Dr. Devendra. As you mentioned, this was a case of type 4 choledochal cyst. But yes, your MRCP picture, I think, suggestive of type 1 choledochal cyst. I think this was a radiological diagnosis of type 4 choledochal cyst, but clinically, this was type 1 choledochal cyst as looking your operative findings. What do you say?
it was when we tried the resection at the hepatic, sir, it was the bile ducts were dilated, hepatic ducts were actually dilated, sir. So since it was bilaterally involving, we didn't try to do anything, sir. So we just did the hepaticojejunostomy.
What was the indication? What will you suggest for emergency surgery of colorectal cyst?
Sir?
What will be the indication of doing complete repair in cases of colorectal cyst, as in your cases?
Sir, one of the main reason is the incidence of cholangiocarcinoma is very high, sir, with the presence of colorectal cyst.
It was very difficult to manage the inflamed CBD. But
yes, sir.
You were able to manage?
Yes, sir.
So by your case report, you are suggesting someone to go for emergency laparoscopic hepaticojejunostomy in colorectal cyst?
Sir, one of the thing is we did the emergency surgery because the child has an unrelenting pain, sir. Even with the maximum analgesics, the pain was not coming down, which hiked up the antibiotics, so it was not coming down, and we thought it is an impending perforation state, so we went in. One of the reasons, sir.
My question is about open versus laparoscopy here.
Sir, if it is feasible, we can do, sir.
It's okay.
Thank you, Dr. Apit, for being a general surgery resident to present very nicely.
Thank you, sir.
And it's very good that you are following the COVID protocols even inside the closed room by wearing an N95 mask. Thank you. By this, we come to the end of the session 8. We'll move on to session 9 on laparoscopy. The first presenter in the session 9 laparoscopy first session is Gaurav Prasad. Dr. Gaurav Prasad, are you ready?
Yes, sir. I'll just share my screen, sir.
The judges for this session will be myself, Dr. Deepak, and Dr. Ajas. Dr. Deepak, Dr. Ajas, you both are online?
Yeah, Dr. Jagdish, I'm here.
Sir, is my screen visible?
Yeah, your screen is visible.
Good evening to all of you. Today I will be presenting about a single-port, single-instrument thoracoscopic removal of an antenatally displaced intrathoracic pleuroamniotic shunt. I have nothing to disclose. Pleuroamniotic shunt is basically used in the treatment of fetal hydrothorax, which can occur due to a variety of conditions like congenital heart anomalies, lung anomalies, or chylothorax. However, this procedure carries a number of complications, including its non-functioning rear displacement, maternal oligohydramnios and ascites, and even fetal hemothorax due to trauma. The management of displacement of the shunt is not well discussed in literature, and some reports have suggested non-operative management and others an operative management in which either it can be removed by a thoracotomy or a two-port thoracoscopy. We highlight our experience using a single-port thoracoscopic technique. At 28 weeks POG, a primary gravid mother had presented with a non-immune fetal hydrops for which a pleuroamniotic shunt was placed at 32 weeks POG. Subsequently, she developed PPROM and a premature delivery occurred at 33 weeks. Initially, the child required ventilatory support and was then discharged. However, since he was non-symptomatic, he was kept under follow-up, and at 19 months of age, a decision to remove the shunt was carried out. These are the X-rays that showed a displaced shunt on the right side. The surgery was carried out in a prone position and using a coaxial scope, which basically has a working port as well as a camera port in the same thing. Instrument. The crocodile forceps was used to extract the displaced shunt. Shunt displacement is a rare but possible complication of pleuroamniotic shunts. There is an absence of standardized guidelines regarding its management, and single-port thoracoscopy is a feasible technique that can be used by the novice as well as an additional procedure in the armamentarium of experienced surgeons. It provides the advantage of good visualization and shortened post-operative force. Thank you.
Yeah,
Thank you. You can unshare your screen now. Open to the judges, please.
Yeah, Dr. Gaurav, where exactly the shunt was, like in which cavity by removal?
Sir, basically, intraoperatively, it was found to be in the right cardiophrenic recess.
Okay. Was there any additions? How urgent the plane was?
It was actually, sir, we had expected some additions to take place during this period, but there were no significant additions were found, and the station could be retracted easily.
Did they put any other shunt was attempted antenatally after its displacement?
No, sir. Actually, this shunt was done at 32 weeks period of gestation, and at 33 weeks itself, the shunt got displaced, and then the mother also developed a premature rupture of membranes, and a premature delivery was carried out.
Okay.
Dr. Gaurav, I'm Dr. Kanpal here. Nice presentation. To wait for the child to become, 19 months old, and what was the indication for removal of the shunt at that age?
Yes, sir. Actually, initially, the parents were not very. It was a precious pregnancy, so the parents were not very willing to get a surgery done in the initial period. And since the child was asymptomatic, we decided to wait until the child was slightly older to remove the shunt. And secondly, we decided to remove it after all because there are case reports which have highlighted complications, even like wrapping of the shunt around the pulmonary hilum that have led to a neonatal demise. So we decided to remove it subsequently once the child was older.
Thank you.
Yes.
If there are no further questions, can we have Dr. Arun Prasad?
Yes, sir.
Yeah, please share your screen. We can see you now. Please stick to your time.
Yes, sir. Can you hear me, sir?
We can hear you. We can't yet see your screen. Yeah, okay, we can see your screen. You can start now.
Yes, sir. Good evening, one and all. I'm Dr. Arun Prasad. I'm presenting from my Institute of Child Health in Chennai. Today, we're going to talk about pancreatic pseudocysts and laparoscopic management in our center. Pancreatic pseudocysts are collections of pancreas from the pancreas, which has no collection. It has fibrous lining without any epithelial collections. The commonest etiology are the commonest etiology are chronic pancreatitis and traumatic injury, and there are multiple open and laparoscopic management has been done. Excuse me, sir. Sorry, I have a small problem with my computer. So we are going to see about 3 cases of heterogastric pseudocyst over a period of 1.5 years in our center. All of them have undergone laparoscopic management. And we have one first case is an 8-year-old male who fell from a bicycle who had traumatic blunt injury, and he had initially managed by percutaneous drain insertion. And the second is a case of 8-year-old female with acute necrotizing pancreas, and who had initially previously undergone a surgery of laparotomy in 2 years ago, and was managed conservatively since then. And the third was a patient of 10-year-old chronic pancreatitis patient was managed conservatively. All these 3 patients were initially stable, and the patient one who had trauma alone was having a tenderness in the abdomen and mild irritability and tachycardia, which was settled conservatively with initial management. And the other 2 patients were all initially stable, and everyone had a mass of more than 10 centimeter approximately. And on investigations, the first patient, the traumatic injury patient, had a mild leukocytosis with a gross elevation of amylase and lipase. Other 2 pancreatitis patients had moderate elevation with mild hypoproteinemia, who were managed nutritionally initially before the surgery. And on imaging, on X-ray, we had a homogeneous mass pushing over the hepatic collection in all these 3 patients, which will show the pictures next. And ultrasound also showed the collection of the lesser sac with internal echoes and turbidity. And the traumatic patient underwent CCT abdomen, which showed a pancreatic laceration, suspected laceration, along with collection in a way, and MRCP also showed collection in the lesser sac, proving
30
our
seconds.
diagnosis. Yes,
30 seconds.
And this is the X-ray showing the pushing the mass, and this is the MRCP T2 weighted MRI showing the laparoscopic pancreatic pseudocyst, and all of them were managed initially with antibiotic and planned for laparoscopy. And this is one of the intraoperative pictures where we did 10 mm portal supraumbilical and 5 mm marking codes, and we did with the stage switches anti-gastrostomy one time, and after performing by aspiration in the posterior wall, and the posterior gastrostomy was done and the fluid was let out, and edges were overrun, and following anterior gastrostomy closure was done. And following this, patients are all managed conservatively, and post
the time is up, doctor.
Discharged on POD7. Minimal techniques are preferable due to reduced post-operative pain, better cosmosis, and due to shorter hospital stay. Thank you.
Good presentation, Dr. Arun. Your mean hospital stay, as per your abstract, seems to be 18 days in spite of minimal access surgery. So, is there any reason? Was there anything coming in the drain because of which you were waiting for starting early? Or?
No, sir, the only reason they were waiting initially was due to the availability of the hospital surgical timetable. So we didn't have.
Does the hospital stay included the pre-operative stay also?
No, sir. Yes, sir. Exactly, sir.
Okay. Then you could have just put the post-operative stay, which will tell us the impact of surgery. Because for minimal access surgery, we want that
compatibility. Stay more than 1 week, sir. By 1 week, we were discharged all the patients.
Okay.
Please unshare your screen.
Yes, sir.
If there are no more questions, we'll move to the next one. Dr. Gaurav Sharma, are you here?
Yes, sir.
Okay, please start your video and share your screen.
Sir, am I audible, sir?
Yeah, we can hear you clearly.
Am I visible also?
Not yet. Yeah, okay. We can see your presentation. We can see you as well. Good luck.
Good afternoon, sir. So I shall be presenting on a case of bilateral pheochromocytoma in a VHL syndrome. So I'm a junior resident in AIIMS Rishikesh. So this is a 15-year-old male child who diagnosed as bilateral pheochromocytoma. He presented to the pediatric medicine emergency with a complaint of hypertensive crisis, intermittent headache, abdominal pain, and bleeding PR, which was managed with alpha plus beta blockers and PRBC transfusion in the medical emergency. There was a past 4-year history of headache associated with on and off episode of pain, abdominal pain, nausea, and palpitation. He was advised for the pheochromocytoma workup and was diagnosed with VHL syndrome on the genetic testing. Patient did not have any complaint of cerebellar, testicular, or pancreatic tumor, but there is a significant diminution in both of the eye. So in pre-op examination, the BP was on a higher side, more than 90th percentile. Pallor was present. There is no cyanosis, icterus, no clubbing, no lymphadenopathy. Patient was afebrile. The 24-hour urine metanephrine and normetanephrine were raised. On fundus examination, there is bilateral hypertensive retinopathy and choroidopathy, and there is retinal angioma in the left infratemporal lesion. The rest of the systemic examination was normal. On CCT abdomen and pelvis, there is avidly enhancing lesion in the with the internal necrotic areas and foci of calcification in the right adrenal gland, which was around 4 by 3 centimeter in size. You can clearly see here. The similar lesion was also present in the left side, which was around 4.6 by 3 centimeter. The similar kind of presentation was on the left side also. So we did laparoscopic bilateral partial cortex sparing adrenalectomy under GA. The port placement was one was umbilical, which was 10 mm in size, and one was below the right and left 11th subcostal margin, and there is one extra port on the right side to retract the lever. And the perioperative finding of this patient was bilateral adrenal masses of around 4 by 6 centimeter, and the fat planes were maintained on the right side, which was not maintained on the left side, and the cortex was separated from the masses and allowed to fall back, and the vascularity of the mass was clipped close to the mass to supply the remnant, that is cortex here. So post-surgery, patient was put on hydrocortisone and fludrocortisone.
30 seconds.
After 2 weeks of surgery, 24-hour urine sample of fractionated metanephrine were normal limits, and patient was discharged on low hydrocot and without any antihypertensive. Since then, patient was on regular follow-up. So my conclusion was laparoscopic bilateral partial cortical sparing adrenalectomy is feasible for the treatment of bilateral pheochromocytoma or adrenal tumor patient. It avoids the long-term complication of the steroid and Addisonian crisis in such kind of patients. So, thank you, sir.
Thank you, Dr. Gaurav. And I'm Dr. Jagdish here. How was the plane identified between the cortex and the mass? Was it clear plane? It could be just separated easily so that completeness of resection could be assured? Or is it like you were vaguely dividing it between the cortex and the mass?
It was a gross, on the gross specimen, sir, it was, we can see. So
is there any specific avascular side, like medial side or lateral side, in which you split open the cortex?
So
depending on the vascularity of the adrenal.
So it was there in the, sir, in the gross examination it was there, sir, to differentiate the cortex and the medulla.
Okay. Okay, thank you.
Dr. Gaurav, I'm Deepak Anwar here. Thank you for a nice presentation.
Thank you, sir.
And did your patient require any post-operative corticosteroids? And if yes, for how long?
So on a post-operative follow-up, the patient was on hydrocort minimal dosage, which is 10 milligram, without any fludrocortisone, without any antihypertensive. Patient is doing well, sir.
So he's off steroids now?
Yes, sir.
Yes. Thank you.
Thank you, sir.
Good job, doctor. Please unshare your screen. Dr. Bhushan Rao. Dr. Bhushan, are you there? Dr. Bhushan? Okay, we go for the next one. Dr. Madhumita Rajan.
Yes, sir.
Yeah, please share your screen and share your video. Good luck.
Thank you. Am I visible, sir?
Yeah, both are visible. Just yeah, full screen. Perfect. Okay, start.
Good evening, everyone. I am Dr. Madhumita from Sri Ramchandra Institute of Higher Education and Research. I'm going to talk on laparoscopic assisted feeding jejunostomy for corrosive injection. So corrosive injection, as we all know, is a very common problem in developing countries, which poses a very significant challenge due to the devastating effect it has on the upper GI tract. Stricture is one of the important late sequelae following corrosive injection, which can begin as early as 2 to 3 weeks. Feeding jejunostomy is always performed in almost all patients to facilitate early enteral nutrition and to optimize the nutritional status before any definitive reconstructive procedure. So we had a 4-year-old boy who came to us with an accidental injection of an acid. Initially was managed in an outside hospital. And when he came, he had complaints of vomiting after every 2 to 3 feeds. And there was a significant loss of weight of more than 5 kgs over 1 month. Examination revealed a visible gastric peristalsis, and other systems were normal. So we went ahead with a barium meal, which showed a normal esophageal caliber, however, a dilated stomach, and with only a streak of contrast passing across the antrum. So we decided to do a laparoscopic assisted feeding jejunostomy. Boy was very much malnourished and had severe hypoalbuminemia. So we wanted to start on enteral nutrition. So we made a camera port and brought the jejunum out through it. And the other working port was used as the for the jejunostomy. And this is the jejunostomy being done. And so we finished it in the we finished the jejunostomy through laparoscopy assisted, and then check the position under vision as well. So then the upper GI scopy done after 2 months showed antral stricture, but the patient was actually tolerating feeds and was not very symptomatic and had no vomiting. And 6 months later also we followed up with an endoscopy in which the scope was being able to pass through the into the duodenum. So strictures following corrosive injection usually develop within 8 weeks of injection, and caustic substances can cause long-standing strictures as well. Late sequelae, however, as we all know, is due to the gastric outlet obstruction, late achlorhydria, and of course, development of carcinoma. So feeding jejunostomy plays a major role in providing early nutrition for such people, and the minimally invasive procedures can provide a far better outcome in patients as they avoid addition, stricture, and morbidity of a laparotomy. These are my references. Thank you.
Excellent. Well done. Thank you for finishing in time.
Thank you.
The paper is open for the judges. Do the judges have any comments? Any comments from the participants? Okay. Thank you, doctor.
Thank you, sir.
You can unscreen. Yeah. Okay. Thanks. Do we have Dr. Aditi Rangnekar?
Yes, sir.
Okay. Hi. Please share your screen and we can see you. We can't see your screen yet.
Can you see it now, sir?
No, not yet. We can see you now, but we can't see your screen.
Is it visible?
You can either do Alt Tab, or you can, I don't know if you're starting it in the directly in the full screen mode, then just start with the normal mode and then start in the full screen mode. Or if you think you need some time, then we can go on to the next one for now.
Yes, I'm trying, but it's just not able to.
Okay, we'll give you 5 minutes to figure it out. We'll take the next one till then. Dr. Akshay, are you there?
Yes, I'm here.
Akshay bhai, please share your screen and your video.
Can you see me?
Yeah, we can see you now. And your screen as well, please.
Can I start?
Yeah, you can make it full screen and then start, please. Thank you.
Good evening. Can I start?
Yeah, start.
Good evening, everybody. We all know that the pyeloplasty has a significant learning curve, and even after mastering the surgical technique, if you want to go for laparoscopic technique, the learning curve is still steeper. And the question for today is whether we can bridge this gap by using laparoscopic assisted pyeloplasty. Now, these are the different reasons why we would like to go for a minimal access surgery. And here we are, I'm presenting the series of cases which was done between 2018 June to February 2020. There were 12 cases of laparoscopic assisted pyeloplasty and 18 cases of extraperitoneal open pyeloplasty. And the exclusion criteria has included the redo cases, PCN catheters inserted before the surgery, and ectopic kidneys. Now, just brief overview of how it is done. This is a demonstration of left-sided laparoscopic assisted pyeloplasty. Standard 3-port technique. Three ports are inserted. 5 mm for telescope port and telescope, and 3 mm for working port. Colon is reflected. PUJ is identified. Significant dissection is done across the proximal ureter so that we can pull the PUJ to the surface, anterolateral abdominal wall. And where it is feasible, 10 mm port is inserted. Using a Babcock's, the PUJ is pulled out and it is secured using infant fluid tube or umbilical tape. Then incision is extended by around 5 mm on either side, making the incision up to 2 cm for working port. This is in brief the procedure, and open pyeloplasty was done in any other standard manner. The results included the age and weight were slightly higher in the lap-assisted technique compared to the open technique. I'll give you the reason why it is so. In open pyeloplasty, only one patient was female among 18. The duration of surgery, which also includes anesthesia time, was 150, slightly more in laparoscopic assisted pyeloplasty, and it is justifiable. Number of hospital stay was slightly more in lap-assisted pyeloplasty, and this could because of small number and one patient had a complication. And the epidiameter and the side of the kidney both are comparable both the groups. One patient had urinary leak and had required 14 days of hospital stay in lap-assisted pyeloplasty. 8 days of hospital stay was required for one of the open patient because of surgical set infection. 4 patients required extension of the incision. Almost
you
like
have 15 seconds.
That is because and all the 4 patients were above 3 years of age and more than 10 kilograms, and this is the reason why we had high mean of age in laparoscopic pyeloplasty. The scar size was 3 times lesser compared to the open technique. So what are the advantages that surgeon gets? So the beginners, they get to know the orientation of the organ. They get to know the orientation of the port placement.
Your time is up.
And without compromising on the anastomosic technique and without extending much time in the surgery and giving good scar. Thank you.
Hi, Dr. Akshay. I'm Deepak Kandwal here. Thank you for a very nice presentation.
Yeah, thank you, sir.
Yeah. What do you think are the reasons, for this procedure not being good for older children?
Basically, the advantage of laparoscopic assisted pyeloplasty is the body habitus itself. In older children, because of sturdy muscles, it will not be able to pull out the huge junction to the surface, and we need to extend the pyeloplasty. In that case, probably we can go for laparoscopic surgery itself rather than going for minimal access surgery. Laparoscopic assisted surgery.
Yeah. Thank you. Thank you very much.
Thank you.
Dr. Akshay, Jagdish here, and a very good series of cases. And I have 2 queries. One is there any cutoff limit of AP diameter with which we can deliver it easily? Like it should be very well dilated extrarenal pelvis?
No, definitely not. No, definitely not. If you can get the pelvic junction up to the surface, you can operate on any AP diameters.
Okay. Regarding
there are literature which also says that infants are the case selection is very important. Patients less than 10 kgs and less than 1 year of age are you can have better results.
Did you have to keep the children in group A for a prolonged nil per oral because of intraperitoneal approach?
No, actually, in the last slide I have mentioned that we did not really concentrate on this minimal access surgery, the advantage of it in terms of pain management as well as hospital stay. We have treated it as open pyeloplasty. We usually keep the patient in PO for 6 to 8 hours, and we start the feed usually on the same day. And it, although it was a transperitoneal technique, we have started on the same day within 6 to 8 hours of surgery.
Okay, thank you.
Okay, judges, please note that this is Dr. Akshay Kalawant and not the previous one which we had to wait for. Dr. Aditi, this is not Dr. Aditi, so please mark accordingly. Thank you, Dr. Akshay.
Yeah, thank you, Doctor.
Thank you, Dr. Akshay. Is Dr. Aditi available? Are you able to share your screen? Do you want to try? Dr. Aditi? Dr. Aditi Ramnikar?
I'm trying, sir.
Your video keeps coming and going, but we are not able to see any computer screen at all. Okay, I think we've got something now. Just wait.
Okay.
We are able to see a blank white screen now. Not able to see anything else.
Right.
No, we still can't see a presentation. We can just see a white blank screen. Okay, I will move on to the next one for now, and then you can just try again. But this is the last one, so you'll have to figure out something. Dr. Sonal Malviya, if you're there, then please start your presentation. We still haven't heard from Dr. Bhushan Rao Jadhav. If you're there, then please let me know.
Yes, sir. Good afternoon, sir.
Yeah, hi. So we can neither see you nor see your screen.
Hello. Hello. Good afternoon, sir.
We can see your screen.
Yes, sir. Good afternoon, sir. Myself, Dr. Sonal Malviya. I'm from KM Hospital, Mumbai. Today I'm
Can you turn on your video, please? So that the judges can see you.
Yes.
Perfect. And please do full screen again now.
Yes.
Okay, I'm starting your time now. Okay. Good luck.
Yes, sir. Thank you, sir. Good afternoon, sir. Myself, Dr. Sonal Malviya. I'm presenting our experience of laparoscopic cystogastrostomy in two patients with pseudopancreatic cyst via posterior approach. We had two patients, one 2.5-year female child with lump in abdomen since 15 days. Patient was not presented with vomiting, fever, trauma. There was no history of trauma. On examination, the lump was well defined of 15 by 10 centimeter in left hypochondric region, which was extending to epigastric and umbilical region. The lump was non-tender, firm on palpation, partly mobile side to side with smooth surface and moving very little with respiration. And in a 11-year male child, the lump was of size of 6 by 8 centimeter in left hypochondriac region, and it was also non-tender and moving very minimal with respiration. This 11-year male child was a known case of necrotizing pancreatitis also, and he had a history of lump since 3 months. This is the clinical photograph of a 2.5-year female child who had a lump in left hypochondriac region. On provisional diagnosis after clinical history and clinical examination was either mesenteric cyst or omental cyst. This is the X-ray abdomen erect showing the left dome of diaphragm, which is slightly elevated as compared to right. USG abdomen of a 2.5-year female child was suggestive of a bilobed cystic lesion. One was of a size of 7 by 6 centimeter approximately, and the small cyst was of a size of 4.5 by 3.8 centimeter. And DDs were given on USG to be mesenteric cyst, cystic teratoma, and duplication cyst. And so we evaluated the tumor markers also, which were all in the normal range. In a 11-year male child also, there was a cystic lesion, which was of a size of 12 by 8 by 6 centimeter, and around 500 cc of collection was also noted involving body and the tail of the pancreas. These are the CT pictures showing a bilocular cystic lesion displacing the stomach and the pancreas anteriorly and left kidney inferiorly, superior to the bladder. The lesion is homogeneous and hypodense, suggestive of a mesenteric cyst. We chose to proceed with diagnostic laparoscopy, in which we can see the port sites. One is the umbilical camera port of 5 mm, and other are the working ports. One in the epigastric, other in the left iliac fossa, and in
30
the
seconds.
mid-clavicular between the umbilical and the epigastric port. On laparoscopy, we first visualized the cyst, which was looking to be thick-walled. These are the intraoperative pictures. Because the size of the cyst was very large, we aspirated percutaneously the cystic fluid, which was dark chocolate colored. Finally, we did the cysto after dissecting behind the stomach. We did posterior cystogastrostomy. On histopathology of the cyst wall.
Your time is up, doctor. Do you want to summarize quickly?
Yes, sir. So my summaries, I just want to summarize by saying that transgastric, we have different approaches of management of the management of pseudopancreatic cyst. While laparoscopic cystogastrostomy, posterior approach via lesser sac is has an advantage of only one incision on the stomach wall, and there we can do wider anastomosis, and it is a safer operation that is possible. Thank you.
Thank you. Judges, please.
Thank you, Dr. Sonal. Dr. Jagdish here. And as you're telling, posterior approach is easier. And how did you know that it is easy, the plane between the cyst and the stomach are easily separable? Is there at any point did you have a preoperative diagnosis of pseudocyst in this, or your diagnosis was entirely different?
So we had a preoperative diagnosis in DDs. Also, we thought of pseudopancreatic cyst, but there was as such there was no history of trauma, and
Okay.
the lump was there was
No, you are mentioning it is a less adherent cyst, no, but retrogastric pseudopancreatic cysts like are expected to be adherent to the gastric wall. That is the whole concept of cystogastrostomy came with that adherence only. So how do we judge that adherence?
so intra.
Since you have opted for a posterior approach,
Yes.
telling that it is less adherent, how do we know that it is easily separable? And depending, because sometimes the wall of the pseudocyst might be friable if it is little lesser than 6 millimeter. So if we separate and if we lose out some tissue, like will the anastomosis will be optimal, or like in toto you are supporting this posterior approach or an anterior approach?
Yes, sir. So we are supporting posterior approach.
Posterior approach. So that is what I'm asking. If you are separating that plane, which is like by the natural history of the disease supposed to be very adherent, which is the whole concept of doing a anterior approach cystogastrostomy without disturbing that plane. So how do you justify that you will not lose the thickness of the pseudocyst? Like it will become friable, and you might lose some more tissue, no, for suturing, and the healthy margins might not be available, no.
Yes.
I'm just asking as a doubt because we have never approached through posterior till now. Did you have to put any hitch stitch for the stomach?
So yes, sir. We took stay sutures over the stomach, and then we proceeded. Yes, sir.
Okay. Thank you. But otherwise, it is a nice presentation. Very
Yes.
nice presentation.
Yes. Thank you, sir.
Thank you, doctor. You can unshare your screen now. So do we have Dr. Bhushan Jadhav or Dr. Aditi Rangnikar? Have you managed to work out your thing?
Yes, sir.
Yeah. Okay. Good job. Perfect. Okay. Start off.
Yes, sir. Hello, everyone. I'm Dr. Aditi from KEM Hospital, Mumbai, and I'm here to present to you our 5-year experience of minimal access surgery using 3D system in pediatric surgery. Our aims are to assess the applicability, safety, efficacy, feasibility, and to highlight the spectrum of 3-dimensional minimal access surgery in children. Our study period was from February 2016 to May 2021, and performed all thoracoscopic as well as laparoscopic surgeries. The parameters that we assessed were duration of surgery, intraoperative blood loss, need for conversion to open, and length of hospital stay, and along with post-operative complications. We initially started with children who were in the older age group, and as we became confident in operating on younger age groups, we proceeded towards younger children. We had around 10 infants operated by 3-dimensional systems in various diseases. Number of ports used in majority of the cases were 3, and we had to use 5 ports in patients of Cushing syndrome who underwent bilateral adrenalectomy, and splenectomy in ITP and thalassemia major. We had different types of surgeries like appendectomies, pyeloplasties, nephrectomies, nephrouretrectomies, bronchogenic cysts, VATS decortication, choledochal cyst excision, cholecystectomies, and ovarian cystectomies, as well as laparoscopic management of tubal torsions. Mean blood loss was maximum in VATS decortications, and duration of surgeries varied from minimum of 30 minutes for appendectomy to maximum in renal cases. There were some special cases that had some complications later on. There was recurrent bronchogenic cyst, which had a specific anatomy, which could be delineated, which we could see visualized better by 3-dimensional camera. Along with that, surgical emphysema, there were complications that happened in a few patients. Surgical emphysema developed in the postoperative period in VATS decortications and one bronchogenic cyst, excision. One patient of thoracoscopic excision of mediastinal cyst had postoperative chylothorax.
You have 30 seconds.
Yes, sir. Benefits of 3-dimensional laparoscopy are depth perception, image definition, accuracy, surgical precision to perform tasks, improvement of hand-eye coordination because of better spatial orientation, lesser blood loss that we particularly noticed in choledochal cysts as compared to open surgeries. Also, it is cheaper than robotic surgery. This is a short slide on physics involved in stereoscopic vision and depth perception. There are a few drawbacks of 3D that are...
Your time is up, doctor. Please summarize.
So I would like to say, conclude by saying that 3-dimensional laparoscope definitely does give a better vision. There is lesser blood loss that we noticed in our study in 247 patients. Also, the learning curve is short and has excellent cosmetic outcomes. Along with it, it has a very wide applicability in pediatric surgery, which is really good, and it is a good bridge between conventional 2D minimal access surgery and robotic surgery.
Thank you. Please unshare your screen. Brief 1 or 2 questions from the judges and the audience, please.
Is there any cost constraints as far as the patient billing is concerned, if your institution is like charging the patients?
No, sir. We do not charge the patients for 3D laparoscopy separately. The charges for 2D and 3D are the same, which are very minimal. It is 1,000 for simpler cases like appendectomy, and maximum is 2,000 rupees for major nephrectomies or VATS decortication. We do not charge any patient more than 2,000. And most patients we try to incorporate in MJPJY, that is Mahatma Jyotiba Phule, so that it is beneficial.
And the trainees also get trained with the same 3D system? Or
sorry, sir?
Trainees are also getting trained with the same 3D system? Or do you have a separate conventional laparoscopy for initial training?
We do have conventional laparoscopy also, sir. And we usually start off with that and then proceed to 3D.
Okay, thank you.
Thank you, sir.
Okay, thank you very much, judges, Dr. Deepak Kanpal, Dr. Ijaz Baba, and Dr. Jagdish Sundaram. Please note that this presentation was the 9.6. It was 3 presentations before, so please be aware in your marking system. Dr. Bhushandas Zadav has been marked as absent. Thank you, judges. I invite the judges for the next session now, Dr. Vinit Binu, Dr. Nitin Peters, and it's myself. And the presenters, we have about 9 papers. So I request everyone to please stick to their times. Dr. Ahmad Sami, welcome. Please share your video as well. We can see your screen. You'll have to make it full screen and start your video as well. And then you can start the presentation.
Dr. Ahmad, you yeah, you can
perfect.
switch on your video. Yes,
okay,
your time starts now.
Good evening, everyone. I'm Dr. Ahmad Sami from Super Specialty Hospital, Government Medical College, Srinagar, and I'm presenting emergency laparoscopic assisted management of bleeding Meckel's diverticulum. So this Meckel's diverticulum is a congenital diverticulum which arises from the antemesenteric border of the ileum. Omphallomesenteric duct usually undergoes obliteration during the 8th week of intrauterine life. Failure or incomplete obliteration results in Meckel's diverticulum. It is the most common congenital anomaly of the GIT and contains all the 3 layers of bowel with independent blood supply. It's present in 2% population, 2 inches long, 2 feet proximal to the ileocecal valve, with a male-female ratio of 2:1 and is symptomatic usually before 2 years of age, and contains 2 types of heterotopic tissue, gastric and pancreatic. Majority of these cases are asymptomatic, but when they present with the symptoms, they may present with severe hemorrhage, intersusception, diverticulitis, chronic peptic ulceration, or intestinal obstruction. Painless rectal bleeding, maroon-colored hemorrhage, occurs usually due to ectopic gastric mucosa because of the secretion of the gastric acid, alkaline pancreatic juice. It leads to ulceration of the adjacent ileal mucosa and ultimately leads to pancreatic ulcer or the peptic ulcer. The perforation or bleeding from the ulcer may be the cause of this painless rectal bleeding. Diagnosis can be made by the Meckel's scan, the laparoscopy, CT scan, enterochlesis, or angiography. The management, it is usually done by open surgery, laparoscopy, or laparoscopic assisted. Meckel's diverticulectomy with resection anastomosis of the adjacent ileum is done. And if incidentally detected Meckel's diverticulum is found, it should be operated in children. In those patients where the diverticulum is having narrow neck or there is palpable heterotopic epithelium. Aim of this study was to assess the feasibility of emergency laparoscopic assisted management of bleeding Meckel's diverticulum. Children with massive painless bleeding per rectum with inconclusive upper and lower GI endoscopy were subjected to diagnostic laparoscopy. Diagnosis was confirmed and resection anastomosis was done extracorporeal, outside the abdomen by delivering the diverticulum and with the adjacent bowel through the umbilical port. Total of 7 patients were operated during a span of 3 years. 4 were males and 3 females. Presentation was painless rectal bleeding. All of them needed blood transfusion during pre-operative period, usually more than 2. None of the patients were subjected to CT scan or Meckel's scan. All of the 7 patients were referred from the pediatric medicine department. Pneumoperitoneum was created by open technique. 2 ports were used, a 10 mm umbilical port and 5 mm working port. Mean operative time was 55 minutes plus minus 12 minutes. There was no intraoperative complication, but 1 patient present in the post-operative period with adhesive obstruction, which was managed conservatively. Mean hospital stay was 4 days, and histopathology revealed ectopic gastric mucosa in all of the patients. These are the photographs, intraoperative photographs. And this is the last, this picture is the post-operative picture. I conclude that emergency laparoscopic assisted surgery is simple, quick, and cost-effective management for bleeding Meckel's diverticulum and is a better alternative to open surgery. Thank you very much.
Thank you for your presentation.
Thank
could
you,
I ask you, have you tried intracorporeal either stapler use, or have you done that for this or any other surgery?
No, sir. We done it extracorporeally. We took the bleeding Meckel's diverticulum out through the umbilical port, and resection anastomosis was done outside the abdomen.
Sure. Thank you.
Thank you very much, sir.
Thank you.
Is there any other question?
Hi, I'm Dr. Vineet here. I had a question. What was your differential diagnosis in these children with lower GI bleed? What is your other differential diagnosis which you kept in mind?
So these patients presented with massive bleeding per rectum, and all the patients were presented to the Department of Pediatric Medicine. So they presented with shock. So after resuscitation, after blood transfusions, colonoscopy was done in the same department. And due to diagnostic dilemma, these patients were subjected to pediatric surgery department. All of these patients. So other causes of bleeding per rectum, in case of children, it's like fissures. They should be kept in mind. So polyps, because bleeding per rectum. So duplication cysts should be kept in mind. They also cause bleeding per rectum.
Thank you. Nice
intersusception, I forgot.
Nice
Dr.
presentation.
Ahmad,
Thank you.
Dr. Ahmad, Nitin here. So well presented. My only
Thank you very
question
much,
is,
sir.
are these cases done by the trainees or are they done by the consultant surgeons?
So, so the consultants as well as so we actually 5 qualified pediatric surgeons. We have passed pediatric surgery, and we are just working under the headship of Dr. Abdur Rashid. So usually we do the cases, but always under sir supervision. He's always there in the OP. So yes, sir.
Good to know. Okay.
Thank you, sir.
Thank you, Dr. Ahmad. Next presentation is also by Dr. Ahmad only. She can continue with that.
Right, sir.
Laparoscopic assisted management of intra-abdominal cyst. You can share your screen, Dr. Ahmad.
Sure, sir. Sure. Once again, good evening, everyone. I'm presenting laparoscopic assisted management of intra-abdominal cysts in children, and this study was conducted at Super Specialty Hospital, Government Medical College, Srinagar. Intra-abdominal cysts are relatively rare, with incidence of 1 per 20,000 admissions to pediatric hospitals. They're categorized into different categories based on the etiology. Bears and Cleeks have classified them, and based on origin, DPARETS have given us a classification. Mesenteric and omental cysts are termed as cystic lymphatic malformations. Mesenteric cysts are more common than omental cysts. Mesenteric cysts occur in mesentery anyway along the GIT from duodenum to rectum. Omental cysts occur in greater and lesser omentum. Duplication cysts occur throughout the course of GIT. And the aim of this study was to present our experience with laparoscopic assisted management of various intra-abdominal cysts. This was a prospective observational study. All the patients present were included in the study, except for those who are having peritonitis or who were previously operated or were having chronic abdominal pathologies like tuberculosis. After confirming diagnosis, all the patients were planned for surgery. Pneumoperitoneum was created by open method. 2 ports were used, 5 mm and 10 mm umbilical port, 5 mm working port. Cysts were delivered through the umbilical port after the decompression and excised outside the abdomen. 13 children were operated, 8 were males and 5 females. All patients had UIG documented intra-abdominal cysts. Pain was the most common presenting symptom. Abdominal lump was the most common sign. 4 cysts were omental cysts, 4 were duplication, 3 were mesenteric, and 2 were ovarian cysts. Size ranged from 4 centimeter to 8 centimeter. 8 were diagnosed prenatally and 5 postnatally. UIG was done in all the 13 patients. CT scan was done in 9 patients and MRI in 2 patients. 1 patient was documented mesenteric cyst on MRI, but intraoperatively, it was torsion ovary. Lap-assisted excision of the cyst was performed easily in all these cases. There was no intraoperative or post-operative complication. Operative time ranged from 30 minutes to 150 minutes. Average hospital stay was 3 days. So these are some intraoperative photographs. This was ovarian cyst, was torsion of the ovarian cyst, and this is the final picture. So I would conclude and suggest that laparoscopic assisted management of intra-abdominal cysts is quite cosmetically better and is an especially a good alternative for those who are beginners in laparoscopy who are having less experience with the intercorporeal suturing. Thank you very much, sir.
Yeah, thank you, Dr. Ahmad. You're very well within the time.
Thank you, sir.
Over to the judges.
Dr. Ahmad, Nitin here. So again,
Yes,
nicely presented.
Thank you, sir.
Question is that what is your, why do you need to do an MRI and CT scan in so many of these cysts? Usually an ultrasound can quite, tell you what is the cyst going to be like, and you're anyways going in for a diagnostic laparoscopy. Any answers on that?
Yes, sir. So actually it was diagnostic like Dalima in those cases where 9 patients were subjected to CT scan and 2 were subjected to MRI. But like after getting MRI done, we had that intraoperative finding that it was like, the torsion of the ovarian cyst, but MRI has suggested that it was a mesenteric cyst. So to confirm the ultrasound findings.
That was my point. So
right,
most of the imaging in ovarian cysts or any other intra-abdominal cysts maybe you may just go ahead with an ultrasound with a good sonologist.
Right.
So that was my point. Right. Okay. Thank you.
Thank you, sir.
I have a question, Dr. Ahmad. Nice presentation.
Thank you, sir.
Because you've highlighted the importance of training youngsters on this. Could you please tell me what adjuncts did you use? Like what energy sources did you use to remove this cyst, and did you use clips, etc.?
No. So we just delivered the cyst outside the abdominal wall and just excised the cyst outside. So by using bipolar or monopolar cautery, sir.
Okay.
Yes, sir.
So, I would just suggest that maybe, so it's a humble suggestion, that maybe you could start doing this inside the abdomen, and you just need some energy sources to tackle any bleeding, if at all, and some clips to make sure if you got a bigger bleeder, then you can just clip it. Anyway, good luck.
Sir. Thank you very much, sir. Thank you.
Hi, Dr. Ahmed. Vineet here. Good presentation.
Thank you, sir.
You had 8 out of your 13 patients are prenatally diagnosed. So what is the mean age at which these children were subjected to surgery?
So after 5 months to 5 years of age, sir, because they were diagnosed antenatally, they were being sent from the, by doing the antenatal checkup, and antenatal ultrasound has documented that there is some intra-abdominal cyst. So postnatally, some of the children, they did not just report till 4 to 5 months of age. So usually the age was after 5 months we operated, so.
So you meant to say that most of these patients are lost in follow-up and then represented. Is that what you're...
So actually, yeah, patients usually here in Kashmir, here are like circumstances are like that. So patients are usually missed in follow-up and then they come in. It's very difficult to approach hospitals and.
Okay. Thank you.
Thank you, Dr. Ahmed.
Thank you,
and,
sir.
Now I request Dr. Gokulan to share his screen. You can start. The presentation on Rapunzel syndrome.
Good evening, sir. I am Dr. Gokulan, MCH resident. Can you hear, sir?
No, but your screen is not visible. Yeah, now it's visible.
Visible, sir?
Yeah.
Yes, sir. I am Dr. Gokulan, MCH resident from Institute of Child Health, Madras Medical College. I am going to present a laparoscopic management of Trichobaza Rapunzel syndrome. The history: 4 years old female child came with complaints of upper abdominal pain for 3 months duration, along with non-bilious vomiting, habit of swallowing hairs and cotton threads for 2 years duration, 1 episode of passing hairs and stools, delay in developmental milestones. Followed by child investigated with plain X-ray abdomen, USG abdomen and pelvis, and upper GI contrast. This is a plain X-ray abdomen shows there is a distended stomach with mottling appearance. You can see. Followed by the child proceed for ultrasound abdomen, shows partially distended with internal heterogeneity present. There is upper GI contrast. You can see there is incomplete filling defect in the stomach. Incomplete filling defect in the stomach. Followed by child confirmed this history and investigation is Trichobaza. Followed by child planned for laparoscopic Trichobaza removal. This is the intraoperative video. You can see. This is the 3-port technique. Creating pneumoperitoneum, you can see the distended stomach with using the monopolar cautery, creating the dissection in the near to the greater curvature. Gently. Now slowly entering to the stomach using the monopolar cautery. You can see that hairs slowly coming out from the stomach. Now using the bipolar cautery, cauterizing and the upper end slowly to close to the greater curvature and the body of the stomach. Now is dissection going downwards, doing the gastrostomy. After adequate dissection, incision, You can introduce the self-impregnated endobag placed in near to the stomach. The idea of endobag is without any spillage. You want to deliver the trichobasal mass without any spillage because it's very infectious material and they create any infectious material. So without any spillage, you want to deliver the trichobasal mass. Now gently pulling the trichobasal mass into the endobag. So now the bulk of the mass pulling and gently pushing into the endobag gently without any spillage. Gently pull and pushing the mass into the endobag. You can see now you can able to see the tail of the mass slowly. The tail of the mass extending up to the duodenum. Slowly pulling the tail of the mass, pushing into the endobag without any spillage. The most important, without any spillage.
Yeah.
Can see
Time is up,
yes,
Dr.
Sir.
Gokulan.
Yes, sir. This is the delivering that specimen. This is the specimen. Now discussion. The bazaar is a mass found trapped in the gastrointestinal tract. It's types of bazaars like lactobazar, pharmacobazar, phytobazar, and plasticobazar, and trichobazar. Symptoms occurring in the psychiatric patients: abdominal pain, nausea and vomiting, loss of weight, and vitamin B12 deficiency. Investigation says that the history, diagnosis, the plain X-ray abdomen, CT, and upper GI endoscopy. So complications: gastric mucosal erosions, ulcerations, perforation of the stomach, and intestine, endosusception, protein entering, losing enteropathy, and pancreatitis. Treatment-wise, the laparoscopy and the laparotomy and endoscopy. This is the first time we perform laparoscopy trichobasal removal in ICH. Thank you.
Thank you, Dr. Gokulan. You can stop sharing your screen and continue with the discussion. Over to the judges.
Thank you, Dr. Gokulan. I think this is a very nicely demonstrated video, and I think you did very well and nicely presented as well.
Endocarpal knotting also is there some video.
Sorry?
Endocarpal knotting of stomach closer also there some time starting of time.
Sorry, I didn't hear you actually.
No, sir, the closure of the stomach, endocarpal suturing also there some video, but starting of time.
Okay, okay. So, how many ports did you use in total at the end of by the end of the procedure? How many were you using?
Using 3-port techniques, sir. But the one stays which is taken stomach wall to the abdominal, stomach with the abdominal wall stays which is outside. Other than 3 ports, sir.
Okay, okay. Thank you.
So, hello, Gokulan. Yeah, yes, good presentation. 2 questions. Was there any SSI in this patient? Because in spite of you using a bag, there is high chance of surgical site infection in these patients. What was your experience?
Post-operatively without any complications, patient went well and
okay. And one small suggestion is there, whenever you present any radiology or any other imaging of the patient's name should be concealed. So okay, that was not done in your presentations. That should be looked into for future presentations. Thank you.
Hi, Dr. Gokulan. This is Vineet here. Do you think that there are any contraindications to doing a laparoscopy for patients with trichobasa?
No contraindications, sir. Without any spillage, you can proceed.
I think one of the important things that you need to remember is that the size of the trichobasa is a very important factor, because if you've got a bigger size, your child is a 4-year-old. So most of these children present very late. So you need to know that the bigger the size of the trichobasa, you'll not be able to, even open surgery is actually difficult to deliver it out of the stomach. Okay, good presentation, good video. Best of luck.
Thank you. We can go to the next presentation by Dr. Pujana.
Yes, sir. Yes, sir.
You can share your screen. You are visible, but screen is not yet visible.
Okay, sir. 1 second. Good evening, everyone. Myself, Dr. Pujana, MCS resident in the Sanjay Gandhi PGA Lucknow. I will present a recorded audio version with my presentation.
Greetings from Sanjay Gandhi PGA, Lucknow. We aim to describe our surgical technique of lap and ureterostomy in a newborn with a VUJ obstruction associated with anorectal malformation. 3 kg male neonate with antenatal diagnosis of left hydroureteronephrosis was born with absent anus, meconuria and penoscrotal hypospadias. In emergency, high sigmoid loop colostomy was done on day 1 of life. During colostomy, left dilated ureter was seen. Ultrasound showed left gross hydroureteronephrosis. BCUG showed no reflex. Renal dynamic scan showed obstructive drainage on left side, suggestive of obstruction at VUJ. Left PCN was done on day 7 as a temporary measure. On day 21, lap and ureterostomy was done. These are port positions, and this is the position of patient similar to the lap pyeloplasty. On entry, we can clearly see the dilated ureter tapering towards the VUJ and also the dilated rectum. Dissection of the ureter was started. Here we consciously used the scissors for dissection instead of cautery, as thermal damage in the newborn can damage the adjacent organs like vas, bladder and bowel. Vas is carefully dissected and separated from the lower ureter. Further dissection of the ureter is done to gain the length. Here we can clearly see the dilated ureter and tapering towards the VUJ. Careful dissection is a must to preserve the blood supply. This is the left obstructed megaureter. Clipping of the ureter is done at the VUJ, and then division of the ureter was done. Through the suprapubic port site, ureter is exteriorized. Left hand ureterostomy is fashioned by taking the mucocutaneous sutures. Ureterostomy functioned well in the post-op period. Child underwent PSRP at 3 months and waiting reimplantation. Megaureters can be obstructed or refluxing or a combination of both. Primary obstructive megaureter is more common in the males, and there is a predilection for left side. After cutaneous and ureterostomy, reimplantation is usually done at 1 year of age. In conclusion, lap and ureterostomy is feasible and safe option in the neonates, especially in cases like ours where colostomy is done for ARM.
Thank you, sir.
Thank you, Dr. Pujana. Your timing is perfect as per pre-recording. Go to the judges.
Dr. Pujana, so at what age was this end ureterostomy done? I could not get that part.
Sir, at day 21 of life, sir.
Day 21 of life. And
Yes,
you had done a colostomy earlier on?
day 1 of life, sir. Child presented with meconuria with absent anus. On day 1 of life, we had done the colostomy.
Okay. And did you have any antegrade study, any EC scan or anything before this? How did you diagnose a megaureter? Just on the ultrasound or any antegrade scintigraphy or any other MRU or IVP or any other imaging?
Sir, this is an antenatally diagnosed case of the left hydroureteronephrosis, sir. And after birth also, we have done the voiding cystourethrogram and also the renal dynamic scan, sir, which showed the obstruction drainage on the left side.
No, which scan did you do?
So what Dr. is asking you is that what was the indication? Why was the end ureterostomy done?
Yeah.
Sir, there is a gross hydroureteronephrosis, sir, on the left side. And as we have seen on the renal dynamic scan also, it is a compromise in the renal function on the left side.
Usually the renal dynamic scans done at this age it's difficult to ascertain whether it's a ureteral obstruction or a PUJO.
Yes, sir.
It's very difficult for the nuclear medicine people to tell you that. So
Yes,
that was my concern, that could you have waited for a little longer time to do this? I mean, the procedure went off very well. Congratulations on that. But I'm
yes,
just curious about the indication.
sir.
That,
Clinically also, sir, there is a palpable lump on the left side over the colostomy and all. So because of that, only we proceeded with the ureterostomy, sir.
So there was no PUJ obstruction here, as Dr.
No,
Nityan was asking.
no, sir.
Okay. Okay.
okay, fine. Thank you, Doctor.
Thank you.
Thank you, sir.
Hi, Dr. Punjana. This is Dr. Vineet here. Was this patient amenable for a cystoscopy and a JJ stenting for this patient? Because normally, I think the first thing that you would normally do is a cystoscopy and JJ stenting. Was that attempted for this child?
No, sir, not done.
Okay. Okay. Thank you.
Thank you. We'll move on to the next presentation by Dr. Abhishek.
Yes,
sir.
Dr. Abhishek, you can start
Yes.
sharing the screen.
Yes. Is it visible, sir?
Yeah, you should make it slideshow.
Yes.
You are not yet visible. Switch on your camera.
Just a minute, sir. Karthik.
Yeah. Now you can start slideshow and start presenting.
Is
The
it
time starts now.
Okay. Good evening, everybody. Today I will be sharing our experience in laparoscopic hemi or total nephrectomy. So we had a total 11 patients of age 2 to 12 years. Majorities were female. My most common presentation among them was renal lump with or without pain. Other presentation was recurrent UTI and fever. Apart from routine blood and urine investigation, USG, KUB and renal scan was done in all the cases. 4 patients of age 2 to 6 years with unilateral renal lump who underwent ultrasound whole abdomen suggestive of multicystic kidney, and DMSA scan showed function less than 10% in all cases. All 4 patients underwent lap nephrectomy. 2 patients presented with large tender renal lump with high-grade fever. There was leukocytosis and ultrasound done which was suggestive of pyonephrosis. So on emergency basis, USG guided drainage was done with pictal catheter, and after the patient stabilized, 4 weeks after that, renal scan was done which showed function less than 2% and 4%. They also underwent lap nephrectomy. 1 patient with recurrent loin pain, history of frequency of micturition and low-grade fever. Urine was acidic and there was plenty of pus cells, and he was on ATD for last 4 months. Ultrasound was suggestive of pyonephrosis with perinephric abscess, and DMSA scan was suggestive of no function in the involved kidney. He also underwent lap nephrectomy. 4 patients of age 6 months to 4 years with recurrent urinary tract infections, high-grade fever, and there was leukocytosis and raised CRP. Urine routine showed plenty of pus cells and culture was positive. Ultrasound was suggestive of dilated upper moiety with echogenicity, and DTPA scan showed poorly functioning involved moiety. All 4 patients was managed with laparoscopic upper polar nephroureterectomy. These are the port placement and position of the patients in either side of the involved kidney. So, transperitoneal approach was taken in all the cases, and after reflecting the colon and ureter and the kidney was mobilized, and after excising the kidney, the resected kidney are taken out from the one of the port side. And in 2 cases of the large multicystic kidney disease, before delivering it out, the cyst was aspirated. So post-operatively, there was minimal pain. Recovery was early. It is cosmetically excellent and operating time was less. and patient can be discharged within a week. So to conclude, I would like to say lap nephrectomy is an excellent procedure for the management of renal surgical pathology. Thank you.
Thank you. You're exactly on time. Over to the judges.
Yeah, hi Abhishek. Just one question. What was your histopathology reports in those patients you said were large MCDKs? Generally, MCDKs tend to be very small.
It showed
renal masses.
dysplastic. The histopathological report showed that the kidney was dysplastic, sir.
Okay. All right. Okay. Thank you.
Dr. Vineet, Dr. Kant, do you have any questions?
No.
Hi, Abhishek. Hi, Abhishek. What was in Vineet here? What was the indications for surgery for MCDK kidneys? Why did you decide to remove them?
Sir, in those 4 patients, 2 of the patients were having hypertension with recurrent episodes of urinary tract infection, and 2 patients presented with multiple history of multiple episodes of hospitalization for urinary tract infection. So to prevent the other contralateral kidney, we have to take out that involved kidney, sir.
Okay. Thank you. Good presentation.
Thank you, sir.
Thank you, Dr.
And
Abhishek.
before you finish, a humble request to keep children's faces off the video. Thank you.
I request Dr. Deepak Kumar.
Yes, sir.
Yeah.
Am I audible, sir?
Yeah, you're audible and
Yes.
you're visible. You can start. You have 2 successive presentations. This is your
Yes,
first
sir.
one. Yeah.
A very good evening, respected sir. Today I'm going to present a video on laparoscopic duodenal atresia repair. Our patient presented on day 6 of life with abdominal distension and bilious vomiting with barium enema. We saw features of obstruction in the 4th part of duodenum. So with port placement, after giving pneumoperitoneum, port placement was done, and first abdominal cavity was inspected, and a stay suture over gallbladder and stomach was taken over trans abdomen. So the part of duodenum was identified, and we have started dissecting the duodenum. A blunt and sharp dissection was started, and we have mobilized the all part of duodenum, 1st, 2nd, 3rd, and 4th till ligament of Tedge. So now here we can see the 4th part of duodenum, which can be mobilized here. So after mobilizing the duodenum, we'll make out that dilated part that is in the 3rd part of duodenum and the collapsed 4th part of the duodenum. With this dissection, we have completely mobilized the duodenum. So now we can identify the dilated part, and with monopolar, we have given a longitudinal incision over the 3rd and 4th part of the duodenum. So we can make out a narrow part, that is the diaphragm, over the part of duodenum. So the membrane or diaphragm which was present was excised, and a clear flow of bile was seen from the duodenum. The membrane was excised, and anastomosis with 5-vicryl in a continuous fashion was performed. And at the end of surgery, there was a good anastomosis, and patient did well in the post-operative period. And now patient is under follow-up of 4 months, and patient is doing well after the surgery. This is the part. Thank you, sir.
Thank you, Dr. Deepak. You're within the time. Over to judges.
Yeah, Deepak, nice video and good intracorporeal management of suturing of this duodenal duodenostomy. Two
Yes, sir.
questions. One is that do you always do a contrast study in all your patients of duodenal atresia? Is it
So
a institutional?
most of the cases we do contrast studies, sir.
Uh, what extra additional information do you get in that?
Sir, actually,
Because
this patient, sir, in this patient, sir, there was not much distension of abdomen, and patient came to us on a 6th day of life. So that time we could not and in X-ray picture also we could not get clear double bubble signs. So we went for a barium study. In that we could see that dilated duodenum and part of dye was going to the other part of the boil like jejunum and ileum, sir. So
your diagnosis of a web was pre-operative diagnosis.
Yes, sir.
All right. Okay. Thank you.
Hi, Abhishek. Dr. Vineet here. Do you always need to exercise the diaphragm in these patients? And what is the risk of exercising the diaphragm?
Sir, in most, we have to exercise the diaphragm, sir. And if we exercise the diaphragm, the risk is we can damage the posterior wall, sir. We can open the posterior wall.
You end up having to do a duodenal duodeostomy, right? Did you
Yes,
do
sir.
a duodenal duodeostomy? So why do you need to exercise the diaphragm? You're doing a bypass already, so you don't
Yes.
need to. Do you need to really exercise the diaphragm?
With intact diaphragm, sir, again, lumen will become a small, sir, after.
Okay. No, Dr. Deepak, actually what Dr. Vineet is saying that you don't need to exercise the diaphragm. Sometimes the bile ducts open in the diaphragm and it can be very dangerous to exercise the diaphragm. So you have to be very careful to do it laterally if you even have to do it. And you're anyway doing what he's saying is you're anyway doing a bypass. So you bypass the diaphragm as well. So it won't actually matter. Anyway, thank you very much.
Okay, thank you,
thank
sir.
you.
Thank you. Dr. Deepak, you can go on with your next presentation on ureterostomy.
Yes, sir.
And share your screen. Yeah, your time starts now.
Again, good evening, respected sir. A 1-year-old girl presented with urinary incontinence with episode of UTI and with suspicious of right duplicated pelvic calyceal system with duplicated ureter. IVP for this patient was done, which shows right pelvic calyceal system dilation and ectopic ureter. So we have planned a surgery for this patient and a laparoscopic approach for this patient. So after port placement, so we have first we have identified the both ureter, the dilated one and the normal one. So with SAP and blunt dissection, we have started mobilizing the ureter, and clearly we can make the dilated ureter and the normal ureter. Stage suture was taken over the normal ureter, and a longitudinal incision was made over the normal ureter for the anastomosis. And before this procedure, cystoscopy was done for the patient. At the time of cystoscopy, a DJ stent was placed in the normal ureter. A longitudinal incision was made over the normal ureter. So we have started the anastomosing from the corner suture. First posterior wall has been repaired. After completing the posterior layer, a stage suture has been taken over the dilated ureter. A trans-abdominal stage was taken, and to clearly identify the wall for anterior wall of the anterior wall anastomosis. So the anastomosis was done, and patient is on follow-up. 1 year follow-up. Patient is doing well, and patient has subsided their symptoms. There is no dribbling and all, no episode of UTI to the patient. Thank you, sir.
Thank you, Dr. Deepak. Time is well managed.
Excellent video. Could I ask you what suture material you have used? What size particularly?
So 5 likely we have used, sir.
Okay, it looked pretty big in there. So, how old was the baby?
Sir, this patient was 1 year old, sir.
That's why. So, do you find any difference? Have you tried to use PDS? Do you find any difference in that? Are you doing this yourself, or is this one of your colleagues who has done this procedure?
Our consultant has done, Dr. Vaibhav Pandey, sir.
Okay, fine.
Yes.
So, Deepak, again, thanks, Jagdish. So, Dr. Deepak, so again, a nice video and a good demonstration. Question again is that question or more of a comment that it would have been probably better if you showed us the antegrade and the antegrade scintigraphy, the renal scintigraphy in the pre-op and post-operatively, because when you say patient is doing well, it should be given some objective data on that. Other than that, no questions or comments.
Yes.
No questions from me. My questions are already answered by Dr. Nitin, sir. Thank you. Good presentation.
Thank you, Dr. Deepak.
Thank you, sir.
Now we'll move on to the presentation by Dr. Abhijit Kumar. Dr. Abhijit, are you online?
Yes, sir. Am I audible?
Yeah, you're audible and visible. Your screen is yet to be shared.
Just a moment, sir. Is my screen visible, sir?
Yeah, but it's scrolling.
Yes,
I think you have to select the PowerPoint screen. You are selecting the Zoom screen again.
Yes, sir.
Yeah.
Yes, sir. Is it showing now?
Yeah.
Good evening, everyone. I'm presenting a case of vesical urothelial papilloma, which was associated with right lower ureteric calculus. A patient was 8-year-old male child. He had pain in right flank on and off for last 3 months with 1 episode of hematuria. USG KUP was done. We showed right distal ureteric calculus along with the bladder mass lesion at the level of right vesical ureteric junction. CT-IV was done and the findings were confirmed. This one is a coronal view, right side showing the calculus and the ureter. On the left side, there is a transverse cut showing the soft tissue density in bladder. Renal scans were done. We saw normal cortical function and progressive unobstructed drainage of the tracer through the dilated tortuous ureter on right side. DMSA scan showed no photopenic area or scar. Left kidney was normal on both scans. So we planned for cystoscopic excision biopsy of the vesical mass along with right ureterolithotripsy, SOS lab right ureterolithotomy. Cystoscopic excision of the mass was done. This is a short video showing the findings. There was mass present at the level of right VUJ. It was excised using hook and cautery, and the specimen was taken out using DJ holding forceps. We tried to introduce guide wire through the right ureteric opening, but we could not negotiate it. So 3D laparoscopic right ureterolithotomy was done, and calculus of size 2 into 1.5 centimeter was retrieved. DJ stent was placed. This is the intraoperative picture showing the calculus. Histopathology report showed papillary configuration, fibrovascular core lined by transitional epithelium, no nuclear atypia, and pathologic diagnosis of urothelial papilloma was made. DJ stent was removed after 6 weeks, and after 2 years of follow-up, patient is healthy and asymptomatic. Coming to discussion, urothelial tumors are uncommon in children. Incidence is very low, and urothelial papillomas form a very small fraction of all these cases. Bladder calculi is known to be associated in adults with bladder neoplasm, but no such association is known for ureteric calculi and bladder mass. In pediatric population, due to paucity of cases, no association is yet established. To conclude, it was an uncommon case of urothelial papilloma in a child, and coexistent lower ureteric calculus makes this case even more unusual. Thank you.
Thank you. You're within the time. Over to the judges.
No, good case. Well done. I don't have any comments.
Thank you so much.
Nitin sir, Vineet, any comments?
No comments. Thanks, Yogesh. Good presentation.
Okay, thanks. Sorry. So just one quick comment. It's a good case. You first attempted a URS. That's what you were saying initially.
Yes, our plan was to introduce the guide wire and do a ureterolithotripsy using holmium yak laser, but we could not negotiate the guide wire into the ureteric opening. So lab first.
Okay, I missed that part. Okay, so no further questions. Thank you.
Thank you, sir.
Now I call Dr. Deepthi. Are you there online?
Yes, sir, I'm here.
Yeah, you can share your screen.
Yes, sir.
This is the last presentation of the session.
Shall I start, sir?
Yeah, your time starts now.
Good evening, everyone, and greetings from PGI Chandigarh. We had an interesting case of infantile hypertrophic pyloric stenosis with neonatal neuroblastoma, which we managed laparoscopically. We would like to present this case in this forum. So, 29-day-old female presented to us with recurrent episodes of non-bilious vomiting for past 7 to 10 days. She had signs of dehydration, but on abdominal examination, there was no mass palpable. Blood gas analysis revealed metabolic alkalosis as expected. Ultrasound abdomen showed hypertrophic pyloric channel with dimensions of 4.2 into 20 millimeters. There was an additional surprising finding of right adrenal mass with calcification. So we further evaluated with CT abdomen, which confirmed the diagnosis of right adrenal neuroblastoma. After stabilizing the patient and correcting the dyselectrolytemia, we planned for the surgery. Since the child was already undergoing surgery for IHPS, we decided to go ahead with right adrenalectomy as well. Port placement was done as shown in this figure. We used a 5 mm camera port and 3 mm working port. An additional left hypochondrium port was placed to retract the debug to facilitate right adrenalectomy. This is the intra-op image of the right adrenal neuroblastoma. We follow an early feeding protocol in our department. Hence, the child was started on oral feed 6 hours after the surgery and discharged the next day. Histopathological examination revealed poorly differentiated neuroblastoma, which was negative for NMIC amplification, and MKI was less than 4%. Child is thriving well and shows no signs of recurrence on 3 months follow-up. Coming to discussion, coexisting tumors in patients with IHPS have been reported in literature. In fact, an older study shows that there is a 7.5 times higher risk of childhood cancers in children with IHPS. However, there is no definitive causal association demonstrated between IHPS and neuroblastoma. Coming to neonatal neuroblastomas, more than 90% of the cases regress spontaneously and require only expectant management. So why is our case unique? As per our literature search, which was thorough, IHPS with neuroblastoma has been reported only in 2 cases in literature. But in both these cases, neuroblastoma had occurred later and not in neonatal period. Ours is the first reported case of concurrent IHPS and neonatal neuroblastoma, which was managed successfully using laparoscopy, which provided us easy access to both the pathologies, ensured oncological principles could be adequately followed, and facilitated an early recovery of the patient. Thank you.
Thank you, Dr. Deepthi. Over to the judges.
Excellent presentation, Dr. Deepthi. I have a couple of questions. Was any preoperative biopsy done? And since you alluded that most of them will regress spontaneously, could you have left it alone?
Sir, we did not do any preoperative biopsy in this patient. As we were already taking up the child for surgery for IHPS and subjecting her under general anesthesia and the stress of surgery, so we decided to do a right adrenal excision as well.
Do you feel that is adequately justified given that your IHPS surgery might last 10-15 minutes compared to maybe an hour or so or two of removing an adrenal tumor, which may be very adherent to important vessels, not to say the least, the renal vessels as well? So were you very confident, or this is an intraoperative decision that was taken, or a preoperative decision was taken?
No, sir. We decided it preoperatively as well. And intraoperatively, we stuck to our decision because we could easily dissect the tumor off with maintaining adequate oncological clearance. And hence, we proceeded with right adrenalectomy along with IHPS. Usually, if it was an isolated case of a neonatal neuroblastoma, yes, we would have followed expected management in this case as well. But since the child also had IHPS and we had to operate for that case, for that pathology, we decided to do right adrenalectomy as well.
So otherwise you would have not intervened?
Pardon, sir?
Otherwise you would have not intervened is what you're saying?
Yes, sir.
Okay, thank you.
Thank you, sir.
Deepti, Vineet here. Excellent presentation. What was the, I didn't get the age one for the child, and how long was the duration of surgery for the patient?
Sir, the child was of 29 days when she presented to us. The surgery lasted for 1 hour, sir, skin to skin.
Total including the adrenalectomy plus the IHPS?
Yes, sir.
Okay, that's quick enough, I think. And was a bag used to retrieve the specimen, or we?
Yes, sir. We used a ProLab bag to retrieve the tumor through umbilical port site.
Okay, excellent. Thank you. Yep.
I won't be, Dr. Kant and Vineet, I won't be marking this paper, of course. So thank you.
Okay.
Thank you, Nitin sir, Vineet, and Dr. Kant. Now our session is over. Now we'll move on to the next session, session number 11, for which Dr. Munir, Dr. Ashish Chabra, and Dr. J.D. Rawat are the judges. And I would like to call Dr. Azita, the first presenter. Are you online, Dr. Azita?
Yes, hello.
Yeah,
Just
you
one
can
second.
switch on your video. Then now you can switch on your, share your screen.
Can you see my presentation?
Yeah, but you have to make it slideshow.
Yes, there you go. Hi, good evening, everybody. My name is Azita. I'm a surgical trainee working in Sheffield. And I'd like to tell you today about our project looking at documentation of intra-abdominal reproductive organs of female inguinal hernias. So this is important due to a condition known as complete androgen insensitivity syndrome, which, as I'm sure you're all aware, is a condition in which individuals with an XY karyotype have a mutation on the gene which encodes for the androgen receptor. So they fail to undergo virilization and therefore develop a female phenotype. So this is, of course, a very rare condition. However, up to 90% of these individuals can go on to develop an inguinal hernia at some point in their lifetime. And this translates to an incidence of 1% of CAIS in phenotypically female patients who present with an inguinal hernia. So the aim of our project was to look at the quality of documentation of internal reproductive organs in phenotypically female patients who undergo an inguinal hernia repair. So our objective was to look at the proportion of patients for whom we have searched for the gonads intraoperatively, either seen them or not seen them, but documented this in the op notes, and the proportion of patients for whom there has been no documentation whatsoever about whether or not we've looked for them. So we looked at all the female inguinal hernia repairs that were performed in our hospital over a 5-year period, looking retrospectively at the case notes and excluding any femoral hernias or abnormal hernias. And this left us with 224 patients, or 227 primary repairs, the majority of which were laparoscopic. So looking at our results, we found that in 85% of our patients, we are successfully searching for the gonads intraoperatively and documenting this in the op note. However, in 15% of our patients, there has been no documentation whatsoever about whether or not they have been looked for. So if we look specifically at our open repairs, we can see that although in 69% of our patients, we have seen the gonads intraoperatively and have documented this, in 19% of patients, despite searching for the gonads, we have been unable to identify them. Now, of course, this is not an unsurprising this is an unsurprising finding, but we just want to emphasize, of course, that this is obviously a very rare condition. And although we are taking this opportunity to look at the gonads intraoperatively, we have to balance this against the risk of causing any harm in the process as well. So if we compare this with our laparoscopic repairs, you can see that we are managing to identify the gonads and document that in 83% of our patients. But even in laparoscopic repairs, in 1% of patients, we have failed to identify the gonads despite searching. And also interestingly, in our laparoscopic repairs, in 16% of our patients, we have not documented anything about whether or not we have searched for the gonads, which is higher than in our open repairs. So all in all, we found 3 patients with abnormal anatomy or potentially abnormal anatomy. Essentially, the key point of this presentation is to emphasize the awareness of CAIS in patients with female patients presenting with inguinal hernias, the importance of assessing the gonads intraoperatively and making sure to document this. Thank you very much.
Over to the judges.
Hello, I'm Dr. Rawat from Lucknow. Very nice presentation. Can I ask one question, madam?
Yes.
Have you any relation of the side of the inguinal hernia in the female, whether it is more on the right or left? Number 1. Number 2, when you are doing the open surgery, most of the time it is basically a sliding hernia in the female, which is content of the fallopian tube or ovary, and once you are squeezing the sac, the things goes down into the peritoneal cavity. So kindly comment on these 2 points, please.
So for the first question, we did find that there was an increased incidence on one side of inguinal hernias. I cannot remember exactly. I think it was the right side that had a higher predominance, and I can't remember. I'm not sure what the reason is for that, but there was a difference in the laterality of the hernias. I'm sorry, I didn't understand the second question.
The second question is that when you are doing open herniatomy in the female baby, you are just reducing the content because most of the time it is a sliding hernia in the female. So during reduction, the content go back into the peritoneal cavity. There is no need of looking the content inside. So yeah, that's why you have seen most of this content from laparoscopic from inside rather than open hernia, as you have mentioned there. Okay.
Yes. So obviously in the open repairs, although we may not ordinarily see the internal genitalia, we're making a point of having a look to see if we're able to see them or not. So to clarify.
So what is the message that in every female inguinal hernia should go by laparoscopy and see the content and then go ahead, or it can be by open also?
Well, you could argue that laparoscopy is better than open for looking at the internal genitalia, yes. But I think the point really for this is not that we have to definitely exclude this diagnosis in all of these patients, but more that we're taking the opportunity to have a look if we can. So obviously some surgeons still prefer to perform open surgery, and obviously in that group it's still important to have a look if possible. But I understand that, yeah, laparoscopy is better at looking at the internal genitalia, yes.
Okay, thank you.
Hi there. Very nice presentation. This is Kant here from Mumbai. I have a comment. When we talk about CAIS, we not only want to look at the gonads, but we want to look at the uterus. So when you're saying that in open surgery, this is looked at, so I suppose only the gonad was looked at. And I think just looking at the gonad, it's a bit of a tough guess to know whether it's a testis or ovary. Most of the time you can, but not always, especially if it's a smaller gonad. And during laparoscopy, did you ever look for a uterus as well, or it is just the gonads that your study focuses on? And the last part of the question is, do you do preoperative ultrasounds for these to specifically look for the uterus and gonads?
So for the first question, in laparoscopy, people have commented on different things. So some people will say that they've seen the uterus and the ovaries, and some people comment only on the ovaries. So really, I've looked at any positive findings of female genitalia, be that the ovaries or the uterus or whatever's been commented on in the op note. We don't routinely ultrasound all of our patients preoperatively. No.
Okay, thank you. That's what most of us do in India, but I suppose I think getting an ultrasound done in UK is not as easy as getting it done in India. But we do a lot of ultrasounds, and there are a couple of institutes which also even do genetic studies or a DNA or a karyotype to look for CIS. So your point is well taken that we need to look for these very actively. Thank you for an excellent presentation.
Thank you.
Hi, Azita. Dr. Ashish here. I have a simple question. Like out of those 224 patients, how many of them are having bilateral hernias? Because in my experience, like most of the patient, like if you compare with the males, most of the female patient, they have bilateral hernias associated. So how many of your patients are having bilateral pathologies on the either side?
We didn't really specifically look at the incidence of bilateral versus unilateral hernias in our data.
Okay. Thank you.
Yeah, just one question, Dr. Ajita. The recurrence rate I observed is quite higher in your study, 7% compared to very recent literature. Any specific reasons for this, and what type of herniotomy was being done in these patients laparoscopically?
So it wasn't a 7% recurrence rate. It was 7 absolute numbers of recurrences, and that was all specifically in our laparoscopic cohort.
And what kind of procedure was being done? Was it layers, bursting? What was being done exactly laparoscopically?
Again, I haven't looked into the specific intraoperative procedure. It was just all of our laparoscopic repairs.
That's okay. Okay, thank you.
Thank you. Dr. Kokilavani, you're ready for the next presentation?
Yes, sir.
Yeah. You can switch on your video and then share your screen.
So I will be able to see my presentation.
Video we can see, presentation yet to see.
Yes.
We were able to see, we can't see anything.
So am I audible and visible, sir? Presentation is visible.
Yeah, you're both audible and visible. You need to make it full screen, please.
Yes.
I'll start your time now.
Yes. Good evening, respected faculties. I'm Dr. Kokilavani from Kanji Kamakoti Child Trust Hospital, here to present a case series of abdominal scrotal hydrocele under Dr. Lakshmi Sundarajan. So introduction, abdominal scrotal hydrocele is an uncommon clinical entity characterized by a double-shaped hydrocele that extends from the scrotum into the abdominal cavity. The common age of presentation is less than 5 years, most of them being under 1 year of age. We are presenting a case series of 7 cases to highlight its pathology, clinical spectrum, and approach considerations. So case details, the age of presentation in our series vary from 11 months to 2.5 years with a median of 1 year, 2 months. 5 presented on the right side and 2 on the left side. Most presented with a tense inguinal scrotal reducible swelling which refills promptly on emptying. 1 child presented as acute scrotum with hemorrhage into the ASH and underwent emergency inguinal exploration. Our pre-op USG revealed abdominal component in half while the others were detected intraoperatively. The hallmark of ASH are the presence of cross fluctuation and prompt refilling. Here's a video showing the cross fluctuation. And this is a video showing the reduction and refilling. On compression over the scrotal component, it got completely reduced. And on pressure over the abdominal component, caused the refilling. So this is the ultrasound image showing the abdominal component in the first picture, and the second picture showing the communication between the abdominal component and the scrotal component. So all of our cases were approached inguinally. The hydrocele sac was traced proximally to the extraperitoneal abdominal component, which was partially excised. An additional PPV was looked for and identified and ligated in all patients. On follow-up, there was no recurrence. So these are the intraoperative pictures. A first picture showing the bulge in the inguinal incision, and the second picture showing the extension of the scrotal hydrocele into the abdominal cavity. So the first picture, the instrument inside was the patent PV sac. While the second picture, black arrow showing the abdominal sac, and the yellow arrow showing the PV sac. So coming to discussion, abdominal scrotal hydrocele starts as a scrotal or inguinal scrotal hydrocele that later extends into the abdomen, causing both connected by the isthmus. So the cardinal features are free intercommunication between the two sacs and non-communication of the abdominal cavity to the peritoneal cavity. It can be simple or complex when associated with complications. Literature have shown predominance on the right side, and our case series have supported it. So based on the direction of the ASH growth, following theories have been proposed, like upward extension of a scrotal hydrocele, downward extension of an intra-abdominal hydrocele, or downward direction of a fluid and upward extension of a hydrocele, with PPV acting as a one-way valve. We have found a PPV in addition to ASH in all our patients. So our pathogenesis fitted into the third hypothesis, where downward direction of the fluid and upward extension of the hydrocele was present, with PPV acting as a one-way valve. So high pressure within the hydrocele causes distension into the extraperitoneal space through the internal ring from below, leading to ASH formation. So surgical intervention is the definitive management. Approach can be via the standard inguinal or the extended inguinal, abdominal, which can be open or laparoscopic or scrotal incisions. The excision of sac can be total excision or partial excision of the scrotal sac or leaving the abdominal one for drainage, or partial excision of the abdominal sac. So our inguinal approach, abdominal component was traced to the internal ring, partially excised and left to drain, but the PP was additionally looked into for the communication and ligated. So to conclude, ASH is an uncommon condition that should be identified and dealt with appropriately. Physical examination and ultrasonography are usually sufficient for diagnosis, but one has to keep in mind to explore for an additional narrow PPV to prevent the recurrence of the hydrocele. These are my references. Thank you.
Thank you. Over to the judges.
Dr. Rawat, very nice presentation, madam. And clinical examination which you have shown is very excellent, that once you reduce the content from the hydrocele, and that will go totally back into the peritoneal cavity. One more differential diagnosis which you can keep in your mind is that we have seen number of cases with the large mesenteric cyst. They can also travel when there is a patent pressure vaginalis, come down into the this inguinal sac into the scrotum, and same way once you press it, it will go in the peritoneal cavity. So you must keep the differential diagnosis of this.
Yeah, Dr. Kokila.
Yes, sir.
Did you do ultrasounds in these patients to look for any upper tract problems?
Yes, sir. Ultrasound was that is whenever we suspect ultrasound, I mean ASH, those cases we have done ultrasound, sir. So the upper tracts and all was normal in those cases. Only in some cases we found it an intraoperatively. Those cases we didn't do, sir. Actually.
You didn't find any hydronephrosis in any,
no,
in any of the cases?
No, no, sir.
Okay, thank you.
Hi, ma'am. Dr. Ashish here. Nice presentation. I have one question only. Like, how many of these patients they have associated lymphangioma, or you can say lymphangioma is an additional differential diagnosis in these patients?
Yes, sir. Sorry, sir, I didn't completely get your question.
I just wanted to ask you about the association or lymphangioma as a differential diagnosis of these kind of anomaly or hydrocele.
Yes, sir. Our patients, none of them had, sir. But yes, we should have a differential diagnosis of lymphatic malformations of this.
Thank you.
Yes.
Thank you.
Thank you, sir.
Yeah, Dr. Jagdish, you can move to next presenter.
Dr. Mudassir Ahmed Magre.
Yes, sir, I am here. Good evening, sir.
Yeah, hi. Please load your presentation. Just give me a minute. Don't start. I'll get back to you in a minute because we're just trying to verify. Do the judges know whether it's a 4-minute or a 3-minute one? Because I'm not able to.
Am I audible, sir? I'd like to confirm. Am I audible, sir?
I think it's 3+2.
Dr. Munir, it's 3+2.
Excuse me?
Sir, it is 4+2. It's 4+2. Dr. Kant.
Yeah.
It is 4+2, which is mentioned in this presentation.
Okay, sir. So maybe, yeah, okay, fine. Okay, Dr. Mudassir, you can start now. Okay, please share your screen. We can see your screen now. So to make it full screen.
Good evening, sir. I'm presenting. The presentation is about perineal testes and corresponding approach of orchidopexy for these testes. I am working at the Department of Pediatric Surgery for Specialty Hospital, Government Medical College, Srinagar. There is disclosure, none to declare, conflict of interest none. It has not been presented, the manuscript as yet in India.
Can you please wait for a minute? Judges, can you hear him well? Because I can't.
I can hear. Dr. Kant.
Your voice is, yes, sir, you can hear well.
He is actually audible, but not very clear.
Yeah, I can barely hear you, doctor. So maybe you can go closer to the mic or increase the voice in the noise.
Okay, sir, I'm doing that, sir. I am presenting for perineal ectopic testes. Testicular maturation and descent is a complex and a multi-stage process. It is influenced by hormonal, genetic, and structural factors. Testis usually follows the route of gubernaculum, but somehow it may land into ectopic locations like perineum, suprapubic, femoral, or contralateral hemiscrotal areas. However, perineal ectopic testes is the rarest of the above. It is seen in only 1% of the cases. It occurs due to poor development or lengthening of segment of a gubernaculum or from obstruction to the entrance to the scrotum. So an empty scrotum does not always mean it is a non-palpable intra-abdominal testis. We should always inspect the perineum and locate a perineal testis, which can be missed if we do not inspect the perineum. The management of undescended testes, usually we operate these children at 6 months of age. However, it is not the case with perineal ectopic testes. They can be operated below 6 months of age or even at presentation. Surgery is indicated even if no hernia is present. We conducted our study which, based on the evidence presented in the literature. We moved the perineal testes to the right location by a parascrotal incision. All the testes in the perineal location have since all the testes in the perineal location have already crossed the superficial view, so it is inguinal incision is not always required. So we present our experience with perineal ectopic testes and parascrotal orchidopexy in these patients. All the patients with history of empty scrotum were thoroughly examined. In case of testes was non-palpable, ectopic locations were inspected. Examination of the perineum was made mandatory in the checklist of undescended testes. From January 2018 to 2020, 7 patients were diagnosed and operated at Pediatric Surgery Department, Government Medical College, Srinagar. All these patients underwent orchidopexy by a parascrotal incision successfully under general anesthesia. Procedure is demonstrated photographically. First, the site of the testis is marked, then the site of incision in the parascrotal sleeve is marked. Then incision is given as is shown in the photograph. The testis is mobilized, the gubernaculum is transected. herniatomy is performed, and a subdautos pouch is created, testis is placed in the pouch, and incision is sutured back. Total of 7 patients were operated. Mean age was 9 months. All the patients had unilateral perineal testes. Right side was more common than left. 3 patients had a patent processus vaginalis. Its lateral scrotum was not well formed in all the patients. Clinical examination alone sufficed in the diagnosis. No other investigation was required. All patients underwent parascrotal orchidopexy. Characteristics of the testicle and its elements were grossly normal. Orchidopexy in scrotal dot of pouch was performed easily in all cases. Post-operative recovery was uneventful. Surgery was scarless in most of the cases. No post-operative complication was made.
You have 30 seconds.
So, conclusion is that we should, in case of perineal ectopic testis, the parascrotal incision is the best to mobilize the testis and fix it in the scrotum, since the testis has already crossed the range. So the take-home message is no need to wait in case of perineal testis, since testis has already crossed superficial inguinal ring. Inguinal approach is not warranted at all.
Thank you, doctor.
Hi, Dr. Madhesir. It's a nice presentation. And congratulations, you have a good number. You had operated 7 patients, and that's a good number. Like, what is the difference in the pathogenesis of these perineal testes as compared to the other normal undescended testes? Like, what is the difference? What do you think is the difference?
I think, sir, in case of there are some ectopic locations of the testis, but I searched the literature, and the most of the evidence is that when there is an occlusion to the entry of the scrotum, this testis migrate to the perineal location, or there is over lengthening of gubernaculum due to some hormonal factors, then it may land up into the perineal area immediately near the anal. It can even reach near the anal opening, this testis, due to over lengthening of the gubernaculum.
Okay.
Very good presentation. One thing I would like to know, in all cases, you have any patent process vaginalis from superficial ring up to the deep ring, or it was not associated at all?
Not in all cases, sir, but we have found them in patent process vaginalis. We found in few cases. 3 patients had a patent process vaginalis. I have documented it in my slides.
Good. Thank you.
Thank you, doctor. Please unshare your screen. Can we go to the next one? I don't really have a name here, but it says histomorphological assessment of testicular remnants in testicular regression syndrome. Is routine excision indicated?
Hello.
Yeah, hi.
Hi, sir. Sorry, my name, I think, was not registered in the thing. I'll just share my screen.
Yeah. You're Dr. Chaitanya?
Yes, sir.
Okay. Share your video and share your screen, please.
So is my screen visible?
Yeah, your screen is visible. You're also visible. Please make it full screen and you can start now.
Okay. Good evening, everyone. I'm Dr. Chaitanya from Department of Pediatric Surgery, CMC Vellore. Today, I'll be talking about histomorphological assessment of testicular remnants in testicular regression syndrome. Is routine excision indicated? Cryptorchidism is a common condition with 5% having impalpable gonads. However, there is a controversy surrounding inguinal exploration and or excision of testicular remnants at the time of operative intervention. The aim of this study was to ascertain the incidence of presence of either the germ cells or seminiferous tubules in the excised testicular remnants. A retrospective data analysis of all excised testicular remnants from 2008 to 2020 was conducted. The testicular remnants were analyzed for age, laterality, and histological analysis. A total of 237 pediatric male patients were identified with a mean age of 3 years. Left-sided remnant was seen in 83% of the patients. 77% boys had an inguinal remnant, 19% had a scrotal remnant, and 3% had an intra-abdominal remnant. Seminiferous tubules were seen in 9% of the specimens. There was no statistically significant difference in the presence of seminiferous tubules based on either the position, site, or age. Germ cells were only found in 3 specimens, that's only 1%, all of them in inguinal remnants. Various studies conducted, Sendron et al. Evaluated 25 people, showed no identifiable testicular elements. Mizuno et al. Evaluated 102, which showed 12.5% seminiferous tubules and 3% germ cells. Ramesh Mark Nataraj et al. Conducted a systematic review of 29 articles showing 10% seminiferous tubules and 5% germ cells, and they found no evidence for routine excision. Testicular retrogression syndrome, also called vanishing testis syndrome, is a rare developmental disorder that represents less than 5% of cryptorchidism cases. It is characterized by the absence of one or both testicles with partial or complete absence of testicular tissue with normal external genitalia. It is thought to be the result of a late antenatal or perinatal vascular thrombosis or torsion. Theoretically, it carries a potential for malignant degeneration in the long-term outcome, and therefore removal of any remnant tissue is a common practice to eliminate this risk. However, no case series has reported germinal dysplasia or intratubular germ cell neoplasia in any of the specimens taken from these patients. There is still controversy regarding the optimal management of testicular remnants in case of testicular regression syndrome. This study contributes to the evidence base for this condition and provides data for Indian population. The need for routine exploration and excision of testicular remnants must be questioned, as only 1 in 100 specimens have germ cells. Thank you.
Thank you for finishing on time.
Sir.
We'll have comments, please.
Dr. Chaitanya?
Yes, sir.
What is the relation of site of TLS to its malignant potential?
Sir, intra-abdominal testes have a 5% risk of developing malignancy, whereas inguinal testes, inguinal remnants have a 1% risk of developing malignancy, sir.
Okay, in your series, you have done inguinal open exploration and all, or you have done laparoscopy?
No, open exploration.
It's all open. Okay.
All open. After doing laparoscopy, if we've seen that there was no identifiable testis and a hypoplastic bias, we proceeded to an open inguinal exploration, sir.
And histopathology, did you study gonocyte to spermatogonia ratio?
No, sir. The ratio we did not study that.
Thank you.
Hello.
Thank you very much, doctor. I think you can. You've already done the thing. So the next presenter, Dr. Suhasini. Please share your screen. Thank you. And share your video as well.
So am I audible and visible?
Yeah, both. Thank you. You can start now.
A very good evening to all my teachers, colleagues, and friends. I'm Dr. Suhasini Gazula, and I bring greetings from ESI Medical College. My slide is not moving. Sorry. Yeah, I bring, sorry, there's some lag in my presentation. Is it visible, sir?
Yeah, we can see it.
Yeah, I bring greetings from ESI Medical College and Super Speciality Hospital, Hyderabad. My presentation for today is the delayed diagnosis in undescended testes, the role of parental awareness and social factors. The background for our study has been that despite the fact that we are aware several guidelines have brought down the age of occupexy to up to 2 years and 18 months and even 1 year, the reality is that we are far from following these guidelines. There are studies from all over the world which are suggesting that less than 30%, and the range is from 10 to 30% children are getting an occupexy for undescended testes at less than 2 years of age. And interestingly, inexperience with UDT and outdated knowledge of healthcare workers are considered as important factors, and not difficult access to healthcare and illiteracy as is expected. As the age at occupexy is considered an indicator of a region's child health services, We wanted to see where we stand, and this was the aim of our study, to conduct a survey on parental awareness of UDT and factors associated with delayed diagnosis. This was a cross-sectional observational study, and a questionnaire was distributed to parents of children with age less than 18 years. And this is a bird's eye view of the questionnaire. An extended questionnaire with targeted questions was given to children, parents of children who presented with UDT to us. Now, a total of 110 parents were interviewed using this questionnaire. Of these, 19 were parents of children presenting with UDT. The demographic data suggested a preponderance of nuclear family and urban population. Interestingly, there were less than 6% patients who were illiterate, and most of them had received a primary or even some were postgraduates. Now, when the questions were asked, the sad facts were less than 50%, that is 48% only knew about this condition called UDT, and only 33% thought it was a surgical problem. Do the parents know about our existence as pediatric surgeons? Yes, but just a mere 55%, and 45% did not know there was a child surgeon. Now, only 37% thought it was not okay to wait for the testes to descend to normal. And the most shocking truths were 30% parents believed that they could wait even up to puberty for spontaneous descent. Now, what was even worse was 6.3% said yes to taking their child for singeing with a hot iron as a modality of treating UDT. Only 41% were aware of the consequences of waiting. However, infertility was their only concern. Coming to parents of UDT children, in our population, 58% presented before 18 months, and nearly half of them approached a pediatrician as their first doctor. Unfortunately, the limitations of our study is that ESI population may not reflect the general population because of a slightly easier access to healthcare, no direct care costs involved, and a more or less direct access to pediatric surgeon. Among the reasons for presenting late, the majority of them were told that either they were not aware about the problem despite having a hospital delivery, or if they were aware, they were not aware of the need to present early to the pediatric surgeon. Coming to literature review, the study of the last 2 decades has suggested that the timing of osteopexy, despite all sorts of guidelines, has not improved worldwide over the last decade. Major causes of delay in referral are poor awareness of families and more so healthcare workers, and a failure of careful examination of the babies at birth. One of the largest cohorts in Germany, which is considered to be a country with a very high GDP, a very good national healthcare service, also said that the level of knowledge in attending physicians and referring doctors was one of the main reasons of the delay. So the conclusions of our study is lack of parental insight towards UDT and complications remains a universal problem. Our study documents the same, and also the lack of awareness of a pediatric surgeon even among educated urban Indian population.
Your time is up, doctor.
20 seconds, sir, to summarize. Despite many of them approaching the pediatricians, they were not told the need for early surgical intervention. Practices like singeing continue to be in vogue. So the take-home message, it's high time that common pediatric surgical conditions are made a mandatory part of all national programs. Compulsory rotational posting of our pediatric friends in pediatric surgery and spending more quality time with our medical colleagues in CMEs. And of course, emphasis by our own associations on community health initiatives in pediatric surgery. Thank you, sir, for your kind attention.
Thank you for the didactic lecture. Over to the judges.
Dr. Suhasini, nice presentation. Actually, it is the need of the hour, and this reminds me of a study done by our senior Dr. Santosh Mahalik. I think this pediatrician and general surgeon, they should be made more aware about these common anomalies among the pediatric population. Nice study, man. Nice.
Thank you so much, sir.
Dr. Rawat, I have a comment. Excellent presentation and very good data you have presented, and you have well said that pediatricians should take a posting in the pediatric surgery unit. I would say not only pediatrician, but even a general surgery resident should also rotate in our department, so that they should also know what are the time when to intervene and when to operate these cases. Thank you very much.
Thank you, sir.
Thank you, doctor. You can unshare your screen now. We go to the next one, Dr. Vibhu Sharma. Please share your screen. Dr. Vibhu, are you there? Okay, we go for the next one. Dr. Amat Usami, diagnosis and management of transverse testicular ectopia. Dr. Amat. We'll take that as a no as well. Okay. Hello, Dr. Amat. We can't hear you. We can see your screen. Please share your video as well.
Dr. Amat, I think you might have to unmute yourself and then switch on your video.
So am I audible?
Yeah,
yes.
Now you're audible and visible.
Okay, thank you very much, sir. Good evening, everyone. I'm Dr. Amat Sami from Super Specialty Hospital, Government Medical College, Srinagar, and I'm presenting our experience. I'm presenting my topic on diagnosis and management of transverse testicular ectopia with persistent Mullerian duct syndrome. It is one of the rarest forms of testicular ectopia. The first case was diagnosed in 1886 by Len Hossack. Now, more than 100 cases of transverse testicular ectopia are diagnosed. 2 testes are present on one inguinal side. Testes cross the midline to meet the opposite testes at internal inguinal ring, in the canal, or in the hemiscrotum. Other names given to this entity are cross testicular ectopia, testicular pseudoduplication, unilateral double testes, and transverse aberrant testicular maldescent. 3 types are there. Type 1 is associated with hernia. Type 2 is associated with persistent Mullerian duct remnant. And the type 3 is associated with genitourinary anomalies like hypospadias. Persistent Mullerian duct syndrome is a form of male pseudohermaphroditism in which Mullerian structures are present in phenotypically normal males. First case was reported in 1939 with inguinal hernia by Nilsson, and more than 200 cases have been reported in literature. Transverse testicular ectopia with persistent Mullerian duct syndrome has been mostly reported in adults, and the first pediatric case was reported in 1913 in a 2-year-old child presenting with inguinal hernia. This entity is a rare clinical entity. Several theories have been suggested about its occurrence. The first one is the adhesion and fusion of the developing Wolffian canals, aberrant gubernaculum, testicular adhesions, defective formation of the internal ring, or traction on testes by persistent Mullerian structures. And PMDS results from failure of synthesis or release of Mullerian duct inhibitory factor, failure of the end organs to respond to Mullerian inhibitory factor, or defect in the timing of the release of Mullerian inhibitory factor. The aim of this study was to present the clinical and the surgical experience in 6 cases of transverse testicular ectopia with persistent Mullerian duct syndrome at a tertiary care center. The importance of abdominal exploration with excision of the Mullerian structures has been stressed upon when 2 gonads are present in one inguinal canal. This is a retrospective analysis of 6 cases of transverse testicular ectopia with persistent Mullerian duct syndrome managed over the last 12 years by studying demographic, clinical, radiological, operative, histopathological, and post-operative records. 5 cases were operated by a single surgeon, and by a single surgeon who is a senior consultant. Another one was, and 1 case was operated by another consultant. A total number of 6 patients were operated. Age ranged from 1 year to 4 years. All the patients present with groin swelling, hernia, and empty hemiscrotum on the opposite side. UAG was done in the patients, which revealed testes present in the opposite inguinal region near the deep ring and presence of the Mullerian structures. Operative procedure was herniotomy with bilateral open orchidopexy and excision of the Mullerian structures. Orthoptic orchidopexy was accomplished after dissection by suprapubic crease incision.
You have 30 seconds, doctor.
Histopathological findings confirmed presence of uterus and fallopian tube. Final diagnosis was made. There was no complication intraoperative or postoperative. These are few of the photographs which I have put in my presentation, which are revealing this entity. So conclusion is this entity should be suspected transverse testicular ectopia with persistent Mullerian duct syndrome in all the cases who are presenting with inguinal hernia on one side and undescended testes on the other side. Surgical treatment involves careful excision of the Mullerian structures without injuring vas and vessel, followed by orthoptic.
Your time is up, doctor.
Thank you very much.
Thank you. Open to the judges, please.
Yeah, Dr. Samath, a very good presentation and a very nice collection of fair cases.
Thank you, sir.
Do you do any endocrinological workup in this patient, or do you specifically look for any endocrinological abnormality in these patients?
No, sir, we have not done any endocrinological follow-up in such patients because 4 of the patients were in, like, they present with hernia, and on ultrasound, we find that both the testes are present on one side and the presence of Mullerian structure, so we did not do.
Okay, any etiology associated with PMDS with respect to endocrinological abnormality?
So it has been seen that Mullerian inhibitory substance, these theories have been suggested that they may be like the cause.
Yeah, right. Thank you.
Ma'am, nice presentation. Do you have the histopathological data as well?
Pardon, sir? I'm not.
Do you have the histopathological data as well?
Yes, sir. Histopathologically, it was confirmed that the uterus and the fallopian tubes, we have that data, sir. That was confirmed post on the histopathology.
Thank you. Nice presentation.
Thank you very much.
Thank you. You may unshare your screen. Thank you, doctor.
Thank you, sir. Thank you, sir.
Dr. Nasira Koya, do we have them? For laparoscopic hernia repair in female children. Dr. Vibhu Sharma and Dr. Nasira Koya, we can mark them as absent. Okay, thank you, judges. Thank you, Dr. Ashish, Dr. Munir, and Dr. Rawat. Thank you very much. We'll move on to the next session.
Thank you very much. Thank you, dear.
We invite Dr. Rakesh Joshi, Dr. Binde Kumar, and Dr. Sujoy Niyogi. Excuse me for that. The session is on COVID-19 and pediatric surgery, and we've got about 8-9 papers to go through. So I invite the first presenter, Mohammed Mukarram Ali. Are you here?
Hello. हाँ जी, वालेकुम सलाम. मैं होगी.
Do we have Mohammed Mukarram Ali? Okay, we move on to the next one. And do we have Dr. Deepak Kumar? Dr. Deepak Kumar?
Yes, sir.
Yeah, okay. Go ahead. Start your presentation.
Dr. Deepak, the timing is 3 plus 2 minutes.
I would just like to confirm if we have all the 3 judges here. Dr. Joshi, Dr. Binde Kumar, and Dr. Sujoy Niyogi.
Dr. Joshi has joined. I'm not sure about other 2.
Good evening, all.
Hello, sir.
Hello.
Hi, sir. I can't see Dr. Binde Kumar here.
Am I audible?
Yes, sir.
Okay.
I'll give them a quick call. Jagdish? Jagadish? Dr. Jagadish?
Yeah. Yes.
I'll give them a quick call.
Will I'll call Dr. Sujay, you call Dr. Binde.
Okay, perfect.
Will start, sir?
No, just wait. Just wait, Dr. Deepak. Just wait.
Yes.
I think Sujoy has joined.
Yes, sir. He has joined. We're waiting for Dr. Binde, sir. Dr. Kant, are you able to reach him? Otherwise, we can start, I think.
Start because I'm not able to get in touch with him.
Yeah, Dr. Deepak, you can
Better
start now.
Better start. I think we have two judges.
Yes,
They
sir,
can hold the presentations. So welcome, Dr. Rakesh. Welcome, Sujoy. So please start with the first presentation.
A very good evening, respected teacher. Today I'm going to present a surgical services during COVID period in pediatric surgery from a tertiary center. There was no disclosure. As we all know that COVID-19 has severely affected all the sphere of life from past 1 year, and like other institute, our institute, that is Sir Sundar Lal Hospital, has been converted to COVID center, and all the mandatory services were shut down to overcome the pandemics. So we have performed a retrospective study to assess pediatric surgery services during COVID-19 in the institution. So we have collected data from January 2016 to April 2021, and the year of the study period of interest was COVID year, that is March 2020 to April 2021. And the record was collected from hospital record section and departmental register, and data was collected regarding the total admission, operative procedure, and outpatient patient. And a projection model was performed, and the statistic analysis was made by ANOVA and Python ANOVA. So coming to the result, as we can see that the number of admission as well as operative procedure and outpatient has gradually reduced in comparison to the preceding year, that is from 2016 to 2019. We can compare that there is a significant decrease in number of cases. So we can note that in gradual decrease in number of cases month-wise at the time of COVID, and along with the NICU admission. So in neonatal emergencies also reduced at the time of COVID, which was around 8-fold. So total admission was around 5-fold, and NICU admission was 8-fold. So there was a worrisome why there was decrease in neonatal emergencies, as we were providing 24-hour services in the hospital at the time of COVID. This graph shows the reduction in the number of cases of operative procedure at the time of COVID from March to April. In few months, we have seen that there is very few cases, and in August, there were 0 cases.
30 seconds more.
So we have analyzed with projection model that all the statistical data was significant. So we can understand that there was reduced trauma cases because of homeborn population and travel restriction, and many of the neonates were unattended. So we can call them as lost neonate. So hospital has made various strategies to overcome this, So limited OPD registration, but still there is fallout in the cases. So to conclude, with restoration of services, we are facing a challenge with long waiting cases and limited OT slot. So with hard work, and together work, so far so good, we can overcome this tide, and we can provide better services at the time of restoration. Thank you, sir.
Thank you, Dr. Deepak. Over to the judges.
Dr. Deepak, it was a very good presentation, good collection of data.
Rakesh sir, you have to unmute yourself, sir. We can see you talking.
Can I go in first?
Yes. Yeah, sir was also talking. He was not unmuted.
Okay. Yes, sir. Please go ahead.
Sir, your chance, sir. I'll go after you.
Sir. You please go ahead.
So, Dr. Deepak, nice collection, but have you even tried to try and reach some of them randomly to know whether some of the children are even alive? Because in MAMC we did it, and we found that many of them had complications, half-treated cancers on stoma. So many of them they were not even alive to make it after the COVID. So I think that could have been another valuable addition to your data.
Okay, sir.
So you mean to say all sort of emergencies were not taken to your hospital? What do you think the reason is?
Maximum of the patient to BHU comes from the peripheries, sir. At the time of lockdown, sir, there was no vehicle facilities. So, and there was no, at the peripheries, sir, there was no person who would refer the patient to the tertiary center. That's why we were getting very less emergencies at the time.
But even during a strict lockdown, medical emergencies were allowed to, go from one place to another place.
Yes, sir. But there was very least referrals, sir. That's why we were getting very less cases, sir.
Do you think that parents are reluctant to take their child to the hospitals?
No, sir. Actually, even parents had a fear to get affected from COVID-19. That's why they were just bypassing not to come from the home.
So do you mean to say that they are neglected newborns because of the COVID?
Yes, sir.
Thank you. If there is no more questions, we can move on to the next presentation. Dr. Kirtika. Dr. Deepak, you can stop sharing your screen. Is Dr. Kirtika available?
Yes, sir.
Yeah, you can switch on your video and start sharing the screen.
Is my screen visible, sir?
Yeah, now visible.
Okay, sir.
Start presenting. Time starts.
Good evening, everybody. Greetings from AIIMS, New Delhi. I'm going to present a case of interception in a COVID-19 patient, a diagnostic and an operative challenge. I have nothing to disclose. As we all know, interception is where a segment of intestine telescopes into itself, and it is mostly primary or idiopathic, but lead points like Meckel's diverticulum or duplication cysts can be seen in 20% of the cases. COVID-19 is primarily a respiratory disease, but it can also be associated with gastrointestinal symptoms. Moving on to my case, my patient is an 8-month-old female child who had presented to the pediatric emergency with complaints of abdominal pain, bilious vomitings, and constipation since 3 days. The patient was febrile and with stable vitals. On abdominal examination, it was distended, soft, non-tender, with no palpable lump. The child had tested positive for COVID, but there was no history of contact with any COVID-positive patient. A bedside rectal wash in the COVID ICU revealed reddish-brown mucus output, which raised the suspicion of interception. That was further confirmed by sonographic evaluation. After an unsuccessful attempt at hydrostatic reduction, patient was taken up for emergency surgery, wherein a perforated Meckel's diverticulum was noted as the lead point in an ileocolic interception, and reduction followed by resection and end-to-end anastomosis was carried out. The postoperative course was uneventful. Moving on to the discussion, 6.6 to 18% of pediatric patients with COVID presented with gastrointestinal symptoms, and co-expression of angiotensin converting enzyme 2 and transmembrane protease serine 2 receptor is essential for the entry of the virus into the cell, and these two receptors have been noted in gastric, duodenal, ileal, and colonic cells. Also, according to a study conducted by Vincent et al., 8 out of 10 COVID-19 positive children had positive rectal swabs even after the disappearance of the virus from the upper respiratory tract. This confirms gastrointestinal involvement in COVID-19 disease. After an extensive literature search, 12 children with intussusception and COVID were identified from January 2020 to August 21. And most of them were male infants. And only 2 patients had prior upper respiratory tract symptoms. Rest of all had presented with abdominal symptoms. A palpable lump was noted on only 2 of the patients. And most of the patients had undergone hydrostatic or pneumatic reduction, with 2 patients requiring ileocolic resection, as that is surgical management. And 2 patients had succumbed to the disease, whereas the rest of them recovered. Yes, sir. To conclude, I would like to say that intussusception can be an unconventional manifestation of COVID-19, and microvascular thrombosis, which is noted in this disease, can lead to ischemia and perforation. Also, the signs of peritonitis may be marked in the presence of COVID, and hence a high index of suspicion and timely diagnosis is crucial in these patients. And postings of residents and faculty in pediatric surgery helps to give appropriate perioperative care to the COVID-positive pediatric surgical patients. Thank you, sir.
Thank you. Over to the judges. Dr. Kirtika, you can stop sharing the screen while the discussion is going on.
Nice presentation, Kritika, and you finished well in time.
Thank you, sir.
Hello. Yeah, can you hear me?
Yes, sir, I can hear you, sir.
So, I mean, whatever you are describing, it is an ideal age for intussusception, right?
Yes, sir.
And all that. So, how you are correlating that with the COVID? Because it is all COVID pandemic era. And you are having classical symptoms of intussusception, and you have already explored it with that is a complicated intussusception. So, I mean, what is your idea behind doing this study?
Sir, in this patient, there was a perforated segment, which is noted intraoperatively, but when the patient had presented to us clinically, the patient had a soft abdomen. And the findings were not correlating with it. And also, when the literature search was conducted, there were many other CDs which were reported in which there was probable association between COVID and intussusception. There are all theories which have been coming up, like I said, the receptor which is present in the ileal cells, and also there are theories which suggest that because of upper respiratory tract infection or gastrointestinal infection, there could be mesenteric lymphadenopathy, which can in turn cause intussusception. There have been no RCTs conducted for proving this, sir, but these are all etiologies, probable etiologies.
Otherwise, also the same etiology is there for intussusception in infants.
Yes, sir.
So how, I mean, that's what I'm asking. Is there something special with the COVID? You mean to say the patient is relatively asymptomatic, even though they are complicated intussusception? Is it like that?
So for this patient, it was like that, sir. The patient didn't have any signs of guarding rigidity or tenderness, tender abdomen when we had examined.
But then how can you explain this? When there is a perforation and there is no peritonitis or there is no signs, how can you explain it with the COVID, or how can you relate this with the COVID?
Sir, in COVID, there's usually decreased immune response, which can be seen in MIS-C, and also in those cases, maybe that could be a possible factor why this patient did not have classical signs of peritonitis, sir.
In fact, in MIS-C and all that, there is an aggravated response.
Immunosuppression is also reported in these patients, sir.
All immune markers are raised. They're quite raised in MIS-C and all that. So though there is a significant contrary to your findings, though there are significant abdominal symptoms, many times you find absolutely non-surgical abdomen, even though after exploration. You can just see the whole edematous, red, angry-looking bowels. That's all. I mean, that's why I'm asking that it is something in a contrary to the findings that in a COVID, many times you get signs of peritonitis or complication, and you find not a surgical reason for that.
I second Dr. Rakesh. I think what he's telling you is the experience we have with dengue hemorrhagic shock syndrome, and many a times acalculous cholecystitis presents like peritonitis, and when you open up, you did not probably need to do a laparotomy. It would have settled on its own. So your presentation is good, Kirtika, but I think we need to give it more time to actually link it to COVID.
Yes.
Okay, sir.
I'm more interested to know that with the suit on, I think it is more difficult to operate with the suit on and the attire on. I think personally it was very difficult to operate on small children.
Yes, sir, but it was not reducing with after hydrostatic reduction also, so we had to take up the patient for surgery.
Okay, thank you.
Okay, sir. Thank you, sir.
Thank you, Dr. Kirtika. Now, the next presentation is by Dr. Apoor Singh. Dr. Apoor.
Good evening, sir.
Yeah.
Is my video visible, sir?
Video visible, and you have to share your screen without switching off the video.
Yes, sir. I'm doing that.
Yeah, it's visible now. You can make it slideshow and start presenting.
Respected chairperson, session judges, seniors, and my dear colleagues. From the Department of Pediatric Surgery at AIIMS New Delhi, I will be presenting the effects of COVID on the patient care delivery at our center during the past 1 year. I have no declarations. The pandemic had a wide impact on the patient care delivery, both urgent and elective. Although the lockdown and the initial unlocking helped in limiting the spread of COVID-19, it also gave the healthcare institutions time to organize and consolidate their resources for the subsequent patient load. On resumption of routine services, there will, however, be still a mountain load of backlogged cases, which can lead to overwhelming of an already strained healthcare delivery system. Hence, we did an audit of the pediatric surgical patients, which were managed at our center during the pandemic, and compared it with the pre-COVID period. This was done with an attempt to understand the backlog of elective patients that a healthcare facility may face on a full-scale resumption of services. It was a single-center retrospective study comprising of the evaluation of patient admission and management data from the hospital records. We considered the COVID-19 period from 1st of March 2020 to 31st of May 2021, with the pre-COVID period being considered from 1st of December 2018 to 29th of Feb 2020. For the purpose of the study, the patients were categorized into following categories. The outpatients were grouped into physical and teleconsultation, where the inpatients were divided into elective and non-elective, with the latter being further subcategorized into semi-urgent and emergencies. As you can see, there was an almost 50% drop in the admission, with the number of elective surgeries as well as the total operative interventions decreasing by more than half. Similarly, an almost 75% drop was documented in physical consultations. The COVID-19 pandemic resulted in a drastic fall in the number of hospital admissions, both elective and emergent. Also, the implementation of lockdown led to a reversal of the outstation to the local patient ratio in the COVID and the pre-COVID period. This could be attributed to strict and non-compliant travel guidelines, as well as due to improper availability of transport facilities to the patients. All being said, the emergency care provided by the institution was rather unaffected. There was an increase in provision of emergency care. Still, this pandemic indeed took a toll on the pediatric surgical patients, as the data shows. All in all, for each day, the elective OTs was non-functional, and average of 5.2 of the enrolled patients were denied elective surgeries. Similarly, outpatient care also took a drastic hit despite institution of alternative measures like teleconsultation. Global data have reported similar effacement of patient care, with a recent study published by the COVID Search Collaborative in Lancet, showing that 1 in 7 patients worldwide had a delay in their oncological surgeries. Other healthcare facilities have also reported similar findings. Hence, there is indeed a striking difference between the patient care provided in the pandemic period as compared to before. This data hopes to bring a better insight into the backlog that the institutes will face post-resumption of routine services, and also help in developing adequate strategies for the same. Thank you.
Thank you, Dr. Apoor. Over to the judges. We are within the time.
Yeah, you finished in time. Good. So just tell me, Apurva, you have studied up to 31st May, right?
Yes, sir.
So what is the situation from May to this October?
Sir, from May...
You have studied pre-COVID and then COVID period. What about this period, these 5 months now?
So in the 5 months post 31st of May, the institute had started OPDs were started, and but the number of patients were limited, and the OTs were running at half of their capacities. So still the backlog is there, sir. It's still building up. It's not being resolved. So the situation has still not resolved.
It's the backlog from patient side, not from the hospital. So that means still you are not, getting patient regularly.
We are getting patients, sir. No. So patients have started to come in. The backlog is from the hospital side.
So you are not able to handle those.
Yes, sir. Yes, sir. Because we still have to fought every day. The OT was closed. Approximately 4 or 5 cases were getting added on, and those patients have, for the past 1 year, they have to be dated and accommodated into the already short strength of OTs that we are running on as of now.
How many days a week you are operating there?
So right now we are operating 6 days a week, but the OT number per day has been is still, we are still at means we are still a short 2 OTs a week still.
So in this your study, pre-COVID and COVID,
yes,
did you find any difference in emergency, or emergency were there as usual?
Sir, in emergency, sir, smaller emergencies such as intussusceptions and appendicitis, which we usually don't see in a tertiary referral center as ours, those were increased during the COVID time. Apart from that, neonatal emergencies did decrease, but the drop was not that much. It was not a significant drop.
And what about the protocol right now? How you manage any patient like coming to your OPD, when they come as an emergency or as a routine patient? What are the COVID protocol right now?
So right now, the COVID protocol of our institute we have stopped COVID testing for admissions. A patient, if the patient is asymptomatic for COVID, the patient will and requiring admission, the patient will be admitted, and the COVID will be done only if an OT is required. But if the patient is symptomatic, then we'll do a COVID.
90% of the kids patient particularly,
yes, sir,
having a COVID, they are asymptomatic. So then how you are going to pick them then?
So the means because the
they are always asymptomatic. Hardly 10% they need some admission, and out of that even 2 to 3% needs ICU admission. So 90% they are asymptomatic.
Yes, sir.
So that means there is no protocol right now. It is all, everything is. You think that pandemic has gone?
So COVID appropriate precautions are being followed still in the hospital premises. Masks and everything is being followed. But the thing of
kids are not wearing masks.
Yes, sir, kids are not wearing masks. That's right. Because of the main reason for letting go of the COVID testing protocol before the admission was because many of the neonates requiring admissions, they had to wait in the casualty for 5 to 6 hours till the time the repo used to come, and there was a risk of hypothermia and dehydration in those patients. So as to overcome that, the institute had decided.
No, we all are eagerly waiting for third wave. So we cannot, let everyone go without any testing. It will be a tough time then. So we have to take precaution till the pandemic is over. In all non-emergency cases, you can go for RT-PCR. In all emergency, you can go for a simple that antigen testing. But you have to, because most of the kids are asymptomatic. This is what we follow. Anyway.
Thank you, sir.
Dr. Sujay, any comments?
No, it was covered. Thank you.
Dr. Sandeep Agarwal has raised hands. Sir, if you want to comment something, you can unmute and tell, sir.
I would like to comment that what has been said has been done for the last 1 week only, from last Tuesday only, that RT-PCR is not required for admissions at AIIMS in New Delhi, because the data showed that for the last 10,000 cases that RT-PCR has been done in our hospital for admission, there was no positivity. The overall positivity in Delhi is around 25 to 27 to 30 cases per day. So looking at all these matters, the policy can be changed as soon as there. So the situation in Maharashtra is different from situation in Delhi. Thank you.
Thank you, sir. Now we'll move on to the next presentation by Dr. Adnan. Dr. Adnan is available.
If not, we can go to Dr. Pranay Gupta.
Hello.
Yeah, Dr. Pranay, please share your screen and share your video first.
Good evening, sir. Yes, sir. Can you see my screen, sir?
Yeah, we would like to see you also. So yes, can you please share your video if there is no logistic issue?
Can you see me now, sir?
No. Okay, you can go ahead.
Good evening. I'll be presenting a single sector audit of impact of COVID-19 on pediatric surgical care from Bangalore Medical College and Research Institute. The COVID virus pandemic has caused a huge disruption in the functioning of healthcare systems across the world since the past year and a half. The aim of this paper is to compare pediatric surgical practices and services in our institution in the pre-COVID and the post-COVID phase. The pre-COVID phase being from September 2019 to March 2020, and the post-COVID era considered as from October 2020 to April 2021. The materials and methods adopted by us are: we retrospectively compared pediatric surgical practices, including elective and emergency surgeries and outpatient services. Data was obtained from electronic databases, OT, IP, and OP registers. Elective cases, RT-PCR was done for all elective cases, and if negative, they would be operated in the regular OT, and if positive, surgery would be postponed. For all emergency cases were admitted in the isolation ward, and if RT-PCR was negative, they would be operated in the regular OT. If RT-PCR was positive, they would be shifted to a COVID OT, and if the case was urgent enough to be operated immediately, we would operate in an isolation OT. These are the results of our retrospective analysis. In the 7 months of the pre-COVID phase, we operated a total of 1,060 cases, whereas in the 7 months following the first wave of COVID, we have operated a mere 311 cases, which is a drastic decline of 70%, including of the 278 elective cases that we did operate, 22 were rescheduled due to the caretaker being positive or the patient being a primary contact. Of the 55 cases operated, emergency cases, 1 was found to be positive retrospectively. A declining trend was also noticed in our OPD and IPD numbers, OPD showing a decline of 50%, whereas IP admissions showed a decline of approximately 40%. Although not in the purview of this report, we have noticed a better improvement in the numbers post the second wave of COVID, that is the past 2 months, where we have operated 166 cases in the past 2 months, with OPD footfall of 1,983 and inpatient admissions of 226. From the data that we have analyzed, I can conclude that the pediatric surgery practices have definitely been affected due to COVID, and there is also a fall in the number of emergency surgery cases that has also been noted. Thank you.
Good presentation. Have you wondered where the emergencies have gone? I believe children were born, emergencies did occur.
Sir, our hospital was declared a COVID center for the duration of the pandemic, the first wave and the second wave. And we've had to refer most of our emergencies and also our elective cases. A few of our elective cases were operated elsewhere. A few have been lost to follow-up, and a vast majority of them have been rescheduled for surgery. So we still have a vast majority of backlog cases that we are still yet to do.
So apart from telling that all over India, even worldwide restrictions to transport and other things, any new thing in your study? I think
so we have seen, although this is not the exact purpose of the study, but we have seen that post the second wave, there has been a significant increase in the numbers with regards to OP, IP, and cases. So it shows that post the second wave, there is probably a better understanding of the pandemic, a better approval with the return to normalcy.
Yeah, correct. My small suggestion, if you carry on this study, I believe you should also make a record and a column for the complications which happened for the long pendency of the cases. I think that would be worth studying.
Yes, sir, definitely. Thank you, sir.
Thank you. We'll move on to the next presentation by Dr. Abhirami Kritika. Dr. Abhirami, you're there?
Yes, sir.
Yeah.
I'm sharing my screen, sir.
Yeah, it's visible. You make it slideshow and you can start presenting.
Can I start, sir?
Yeah.
So good evening all. I'm Dr. Abhirami, pediatric surgery resident from Rainbow Children's Hospital. My paper is on unusual domestic accidents that we encountered during the period of lockdown. COVID-19 curfew has brought a sense of fear and anxiety in both adults and children. Several journals has published these mental issues in pediatric population. Long-term isolation has exposed the children to increased risk of domestic accidents. We have a series of 11 cases who presented to ER with unusual trauma during this 1-year period of lockdown. And the first child is, this child came with the embedded toy in the scalp, which was removed. And this small girl came with the incense stick stuck in her nose. And this child came with a Fevikwik glued to his hard palate, which was removed. And this child came with the epithelialization of the anterior tongue because he has stuck his tongue to the hot water tap spout. He presented with glossitis and drooling of saliva. He required IV steroids and for 1 day, and he was discharged with the oral steroids with the tapered doses. Consequence of children taking inspiration from historical characters, they try to mimic them. This experimental play can cause accidents like idli plate finger constriction injuries. We had 4 idli plate injuries, out of which 1 child required breaking of the plate with a metal saw under IV sedation, and other idli plates were removed manually. And this child, on her first birthday, unfortunately, she was adorned with a gold ring. But in the evening of her birthday, she developed edema of the finger, which she presented to ER. We removed the gold ring with the heavy scissors. And this child presented with the features of peritonitis with a history of magnet ingestion. This child had an X-ray which showed a radiodense magnet shadow. Child was taken up for laparotomy, and we found 3 magnetic balls stuck to the adjacent loops of intestine and causing multiple intestinal fistulations. We did a resection anastomosis was done for this child. And this is the last and the most unusual case. This child was trying to hide inside the pot in her house, and she came with half of her body stuck inside the vessel. We removed this pot by removing gentle rocking and twisting it right to left, and this child was rescued. And to conclude, even with parents 24/7 physical presence, most of them were working online. They were not able to concentrate on their child. So due to the lack of outlets, schools, and added mental regression, kids have experienced these unusual physical trauma compared to the other normal functioning year. Thank you, sir.
Thank you, Dr. Abhirami. We are in within the time. Go to the judges.
Very nice. Congratulations, Foster. I am doing this study.
Thank you, sir.
Dr. Abhirami, again, myself, congratulations. This is a paper worth presenting. I feel this is a very simple and a very useful data you presented and collected. Kudos to you, all your team and all your judges, all your authors in there.
Right. Thank you, sir. Thank you.
We'll go to the next presentation by Dr. Chetna.
Yes, sir. Is my screen visible, sir?
Yeah, but you're not visible. Yeah, both are visible now. You can make it slideshow and start presenting.
Yes, sir. Good evening, sir. Good evening, everybody. I'm Dr. Chetna from Dr. RML Hospital. I'm presenting on influence of COVID-19 pandemic, second wave on pediatric surgery emergencies in a tertiary care center in New Delhi. The emergence of novel virus, severe acute respiratory syndrome causing coronavirus has led to global pandemic and one of the most significant challenges to the healthcare profession. Due to their invasive nature, surgeries may facilitate widespread disease transmission between the patients and the healthcare workers. The surgical community has promptly responded, and the American College of Surgeons has issued a guideline suggesting that the elective surgery should be postponed and or should be performed in an ambulatory center. Impact and response of surgical community, the only exceptions are the most of the oncological and high acuity surgical procedures were performed and non-operative management was considered. Several studies showed that the COVID-19 pandemic affected pediatric surgery services. However, the reports described the effect of pandemic on pediatric surgery practices in general, but did not specifically analyze the frequency of emergency surgeries, pediatric surgeries and the outbreak affected by the outbreak and only provided editorial comments or perspectives. Therefore, we aim to compare pediatric surgery practices, including the number and type of surgery according to the age group before the outbreak, during the COVID-19 pandemic, and comparison between first and second outbreak. The study was performed in RML Hospital, New Delhi from April 2019 to August 2019. And the first wave, April 2020 to August 2020, and second wave, April 2021 to August 2021. Results: the frequency of emergency pediatric surgery during the pandemic was lower than before the outbreak. And despite a drop in total number of emergency pediatric surgery cases, the proportion and type of surgeries according to the age group performed remained relatively the same. Total number of cases performed in pre-COVID time were 166, first wave 83, and second wave 34. As we can see, the total number of neonatal surgeries in 2019 were 42, in 20 were 19, and 21 was 12. And there was similar decline in the number of cases in the age groups. Results: several factors were responsible for the decreased number of cases being performed during the time period of pandemic, including fear of contracting COVID-19 infections at the healthcare facility amongst the parents. These declining trends might be related to the rapid spikes in COVID-19 cases and an increase in the risk of nosocomial transmission of the COVID-19 infection. While the direct health impact of the pandemic can be catastrophic, the indirect impact driven by the depletion of resources and reduced access to the routine care can lead to further increase in the morbidity and mortality. This setback needs a comprehensive strategy to avoid morbidity from the neglected elective surgeries during the pandemic, including proper comparison between the real risk of COVID-19 cross-infection and benefits of considering the importance and urgency of the emergency surgeries, as the risk of morbidity and mortality increases with the delay in the procedure. Conclusion: the pediatric emergency surgeries in our institution have been affected by COVID-19 pandemic. However, the type of cases according to the age group presenting were comparable, and the complications were not affected, as all the surgeries were done with proper precautions in view of ongoing pandemic. It should be noted that the delay of surgeries for time-sensitive and urgent diseases in children might affect their growth, development, and quality of life. Thank you.
Nice presentation.
Thank you, sir.
Thank you for finishing in time.
Thank you, sir.
Can you say what was the difference between first peak emergency and second peak emergency?
Sir, the total number of cases in the first week, actually, I have just taken data of 5 months, the actual COVID pandemic time. In 5 months duration, in first peak were 83. The total number of cases we performed in emergency OT were 83. And in second peak, they had drastically declined to 34.
What do you think the reason?
Sir, actually, in the second peak, our hospital was 70% of the hospital was converted into a COVID, as it is a nodal center for from Government of India. Sir, it was 70% of the hospital was converted as a COVID center. And our ICUs were also converted into the COVID ICUs. Our neonatal ICUs were, NICU was taken over by the COVID, for the COVID patients. And we were shifted to a normal ward where the oxygen facility was also not available. So we were actually not able to accept the patients who required at least oxygen support also. So that was the reason. Yes, sir.
That is the main reason that you are not able to accept the patient.
Yes,
not
sir.
Otherwise, because they must be in equal numbers during.
Yes, sir. Yes, sir.
Period.
Yes,
and
sir.
How many of them were positive, COVID positive?
So none of the patients who've come to us in emergency were positive, sir.
Oh, okay.
Thank you, sir.
Okay, we can move to the next one. Actually, we missed out judges. Please note that the presentation of Dr. Pranay Gupta was missed out. So we're going to do that now. And the presentation which actually happened was Dr. Adnan Syed. So when you are marking, please note the topic carefully. And we're sorry about that. Dr. Pranay Gupta, are you available? Can we take you?
Hello, sir.
Yeah, hi. Welcome. Please share your screen and please share your video before you start. Judges, please see if you can mark the candidates in real time so that there is no mistake in the marking. Dr. Pranay, we cannot see you or the screen. Okay, let us move on to the next one. We will come back to you. Is that okay?
Sir, I think I can see my screen, sir.
Is anyone able to see the screen? I am not. Yeah, okay. Your screen has started sharing now. Okay, please share your video first and then you can make this into full screen. We would like to see you as well. Perfect.
Am I visible, sir?
Yeah, hi, thank you. And please make it full screen and good luck. Your time starts now.
So, good evening all. So today I am going to present the case of COVID-19 induced immunosuppression causing perennial necrotizing fasciitis after PSRP in an infant. So the perennial necrotizing fasciitis following the PSRP is essentially non-existing complication. But if such complication is present in otherwise healthy child, is seen as more sinister pathology. So in my case, a 9-month-old child with high sigmoid colostomy, we planned for the PSRP after the COVID negative RT-PCR on 11th of April 2021. And the standard protocol was applied and PSRP was done. And in the post-op period, we started with a triple antibiotic, ceftriaxone, amikacin, and metrogyl. But from the day 2 of the procedure, child developing fever, tenderness, and the erythema around the neoanus, as you see in the photographs. And from the day 3rd, there is serious fluid discharge also coming, which is come to culture positive for E. coli, ESBL, and sensitive to meropenem and gentamicin. So the antibiotics are modified accordingly. And in the blood parameters, it showed the hemoglobin, TLC, ANC was decreased, and the CRP was raised, which showed that there's some infection and severely decrease in the ANC 1092. So from the day 4, we added the filgrastim to increase the TLC count, and from the next day, child become febrile, but he developed cough, rapid breathing, and stomach diarrhea, and his father comes positive for COVID-19 at home, and so we did the test for the mother and child again, and it comes positive, and we separate the child and shift it to the COVID designated area and start this symptomatic treatment. Day 4, when we added the filgrastim, the hemoglobin, TLC, ANC is increased significantly, and CRP is decreased, and child was symptomatically and therapeutically improved, and we discharged the child on day 14. At the time of the colostomy closure and the day 65, you can see that the neoanus is completely look like normal. And after the 2 months of the COVID positive, child shows this strong titer for anti-SR, COVID, IgG, and antibodies. So my conclusion is COVID-19 can induce neutropenia, which can cause problem during the routine surgery. COVID-19 negative test in children is a standard protocol, but it's not foolproof. So the caregivers also to be tested before surgery, and in impending way, postponed routine surgery should be able to prevent the rare complication. Thank you, sir.
Thank you for finishing on time.
Yeah, Pranay, it was a good presentation. Always good and good to share complications as well. And I see there's a marked improvement.
Yes, sir. Yes, sir.
Was it sensible to add an anticoagulant to the treatment? Because we have microischemia, ischemopathy, coagulopathies are problem there.
Yes, sir, yes, sir. But the child showed that the feature of necrotizing fasciitis and is rapidly increasing, and the ANC is decreased. And then there is no other symptom like any bleeding or other parameters are okay. And platelets are normal throughout the course. So we did not add the anticoagulant, sir.
In this child, you did twice RT-PCR, right?
Yes, sir. For first RT-PCR,
it was negative.
Yes, the first PCR is negative, and after when its symptom is developed, the RT-PCR become positive on the POD6.
POD6. Okay. So how you relate these two conditions?
Sir,
first
maybe
and positive, and your
so maybe the first sample is a false positive, number one, or he's again gained the infection from his mother as father become positive. So maybe the second cause, and to take the sample nasal throat from the infant is a difficult procedure, and to apply the mask to the infant is another difficult job. So the exposure to the child from the mother is very high. So if the mother is positive, a caregiver is positive in infant, the child has high chance to get infected in the hospital itself.
But how do you explain that baby is COVID positive, and that is the reason why there is a development of such unusual complication?
Yes, sir. Sir, in some study, some Spanish study, it is shown that COVID-19 infection caused some dermatological condition like macular papulosis, arterial, libido necrotizing, and necrotic area. And this libido necrotic area which is infected by the bacteria superadly to cause such necrotizing fasciitis in the background of acute onset leukopenia. So with these all things are combinedly cause such a devastating complication which is not routinely seen after the PSRP child.
Agree, 100% agree. But all these dermatological symptoms,
no,
sir. Yeah, they are also seen without any patient being operated.
Yes, sir.
So yes. Anyway, there are so many other reasons also for infection, local infection.
Yes, sir. Yes, sir. But the child developed fever on the period 2, it is not usual things.
Any steroids were used?
No, sir. No steroids are used after only when the child become COVID positive, sir. For the
steroid after that?
After when the child develop COVID positive, he has some pulmonary symptoms. Only that we add the steroid. No, not before that, sir.
Not before that. Thanks.
Thanks, sir. Thanks so much, sir.
Thank you very much, Dr. Pranay Kumar. I think Dr. Chetna has done. Dr. Mohammed Shoaib is the only one left. Do we have anybody else who's left? Have we missed out anyone?
Last one?
Yeah, Dr. Mohammed Shoaib. Hello. Yeah, please share your screen. And before you do, please share your video as well. I'd like to see you as well. Start your video, share your screen, and make it full screen, please. Good luck. We'll start your time now.
Good evening, sir. Today I'll be presenting a paper on challenges during bronchoscopy in background of COVID-19 pandemic and institutional protocol to overcome these challenges. Surgical procedures, including elective and emergency, has been suspended by many of health facilities during this COVID-19 pandemic, and it was challenging for healthcare givers to give similar care as pre-COVID era. Aerosol generating procedures like bronchoscopy were major risk factors, transmission of infection in health workers, making them vulnerable for COVID infection. Our aims and objectives were to study the difficulties faced in bronchoscopy during this pandemic and to study how to overcome these difficulties. The study period was between April 20 to May 21, and total 71 patients who underwent bronchoscopy, including therapeutic and diagnostic, were included. Our institution protocol, all patients who were supposed to undergo bronchoscopy underwent TrueNAT testing for the COVID-19 before the procedure, though we did not wait for the results to take the child for procedure. And patients were sedated before shifting inside the OT to avoid cough reflux. Patients with diagnostic dilemma for foreign body underwent CT chest, like virtual bronchoscopy to confirm the diagnosis before subjecting the child for actual procedure. And minimum staff were allowed inside the OT during these procedures, including anesthetist, senior surgeon, OT technician, and staff nurses were only the persons are allowed. And a strict PPE protocol were followed during the procedures, including transportation of the patient through the separate corridor, and separate OT was designated for this procedure. And bronchoscopy was performed by experienced surgeon to avoid lengthy timing. We used a locally made plastic barrier during the bronchoscopic procedure, where we made a hole within the plastic drape, and the bronchoscope was inserted through this hole. And during this procedure, we used a camera monitor to avoid going close to the patients and going close to the patient. Anesthetic protocols where no awake or emergent intubation were carried out. Prophylactic antiemetics were used to avoid vomiting. Modified rapid sequence induction were used, and active sectioning was carried out. Total of 71 patients underwent bronchoscopy, out of which 65 were emergencies, 51 for therapeutic indications, and the mean age was between 1 to 3 years of age. 75% were male, and total of 61 patients were of unknown COVID status. Out of which one patient was out of which 2 patients were turned out to be positive, and 1 patient was positive before the procedure itself, and one of the parent of the patient was positive before the procedure. So during this entire period of study, none of the staff who were involved in these procedures got infected with COVID-19 infection. Coming to discussion, bronchoscopy is a high-risk procedure because of detectable disruption of mucosa and increased pressure utilized to oxygenate and ventilate the patient during the procedure. Okay. Surgeon who are in close contact with patients airway during the procedure are susceptible because of suctioning and cough reflex. So concluding, bronchoscopy is an emergency procedure for various indication, in particularly foreign body aspiration. With proper pre-procedure and intra-procedural protocols, risk of transmission of infection can be reduced without hampering the care to the patients. Thank you.
Thank you. Open to the judges, please.
Congratulations, sir. Very nice.
Thank you.
Good number.
Thank you.
And in fact, yes, it is a challenging procedure during this pandemic. And you have devised a different method to prevent infection to the healthcare worker. And none of you have infected by COVID, right?
Yes.
And 4 patients were positive out of 71.
Sir?
4 patients were positive.
Yes,
COVID
sir.
positive.
Yes, sir.
Rest of they all were negative, right?
Yes, sir.
So what was the common foreign body?
Most of the time, it was peanuts, sir. Peanut cotton.
Okay. That's all. Nice.
Thank you.
Any question from Dr. Sujay?
Okay.
No, it's actually a very brave and a very good job done. 60 plus number is a good number. But I was wondering, none of the healthcare workers got positive?
Yes.
Yes, sir. None of the healthcare workers who are involved during these procedures got infected, crossly infected with this COVID-19.
So you can find me a job there.
Okay. We thank all the judges, and we thank Dr. Ravi Kanodia, our Honorable Secretary, for such a wonderful program, and including COVID-19 with so many amazing experiences shared from across the country. Thank you very much, everyone. And Dr. Jagdish Sundaram, also my colleague. Thank you very much, everyone, for joining in.
Thank you.
Thank you, Kant. Thank you so much. Joshi sir, thank you very much.
Thank you.
Your expertise was really valuable for all of us. And Sujoy, thank you. Thanks to all the presenters specifically who had worked in this pandemic and then collected all the data and presented to the community of IAPS. So that is really great job done. So thank you. I think that was the last session for today. So we will wind up now. Kant, is there anything else which is left?
No, sir. I hope we've stuck to our timing.
Yeah. I think we were very good on the timings. That's really great. So we will close this session now. Okay, we'll meet again tomorrow at 4 o'clock for the session on urology short papers.
Thank you, sir.
Thank you,
sir.
Thank you,
so
Jagdish.
much.
Thank you, sir.
Good night, everyone.
Thank you.
Good night.